Hi.
Hey,
Yeah. So,
do we have any questions or do you have anything from can everyone hear me?
Good evening, sir. Yes, sir.
Hi, good evening. So yeah, if there's any questions that the students want to put up before we start the session, I'd love to have them because that would make me aware of what the domains are that I need to touch, and I can plan my delivery accordingly.
that's so nice. So, kindly put your questions in the chat box so that we'll plan accordingly to deliver what exactly the candidates want in the session.
And also one thing, the ones who have joined, I want to know at what stage they are. I mean, especially for the doctors, are you in your MBBS or you are doing your MD or you're doing your super specializing anything? Just right, so that I know what is the how to initiate and how to go about things, because the delivery would be a little different if I'm having a major portion of students who are doing their MBBS right now. So that would make it a little easier for me also, and it would make it interesting for you also on the other end. So it would be very very kind of you if you can just write at what stage you are in. For people who are non-medicos, I'm more than glad to have you. Like I cannot imagine this, but I'll also try being as simple as possible, and making it as interesting as I can, definitely.
Hey, all, we have 2 minutes to go. We'll be starting the session exactly at 6:10. Thank you.
Okay, Gagana, I think I'll start addressing everyone. By the time I think more people can join in,
Yes.
we have around 40 participants right now in the group. And I think it'll be good if I start addressing because that'll also make it a little interactive.
Sure. Thank you.
So, um, good evening, everyone. I'm Dr. Navonil, and I'm so glad to welcome you all here. Firstly, thank you to all the ones who have joined here. Uh, Thank you for letting me reach out to you on a topic which, personally speaking, um, it's very interesting to teach per se or to deliver per se, but equally painful and helpless to be seeing these patients honestly because it's not just medicine, it's not just neurology, it's also neuropsychiatry. There's a lot of it's a beautiful wedding. I mean, between these two subjects, neuromedicine and neuropsychiatry. And the more you actually delve into this branch called neurology, you'll actually start finding that it's like an ocean. I mean, you start on one bank and then you cannot reach the other bank because so much of the brain, so much of the human behavior, so much of how it functions has still not been discovered. Even the best of neurologists will say that till today we have only been able to decode 10 or 15% of the human brain, not more than that. Uh, Standing on a date in 2025 right now where whatever evidences we have, that is all that I wanted to include in this. As you know, the topic is neurocognitive disorders, and as I said, uh, uh, you know, as interesting it is to know, equally painful it is to see these patients because we don't have much of options as of now. Researchers are going on, and I can tell you this myself that I am in very close proximity to some of the trials which are going on right now, and I can tell you that yes, we still have a long way to go. So all my juniors, especially who are coming up through these years, and the ones who will want to take up neurology in their future or neuropsychiatry for that matter in future, my only request to you is, along with being a clinician, please also look into the aspect of research because. Like I was having a talk with one of my professors the other day, and he was saying that imagine a person who was a clinician in the 1960s and say he passed away in 2003. When how many drugs of diabetes did we have back then? Hardly two or three drugs. Imagine in 2024 we are going back in a time machine, 2025 rather, we are going back in a time machine and bringing him back to life again. He would be stunned to see the amount of development, the amount of treatment modulations, the amount of the progress that we have made per se in the field of, say, a disease like diabetes. But pick up a neuropsychiatrist, pick up a psychiatrist or a neurologist back in 2003, come up to 2025, neurocognitive disorders, we really don't have much options. The only options that have been still now well established are in the West, and it is a very cost effective plan. Trust me, it's I mean some of the treatment protocols are like 40-50 lakhs per year, and in a country like India it is so difficult to not just afford but also to maintain that setup where we can treat these patients. So I will try my best, being 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 one of those fortunate people, I believe, who has been a very close part of some of the trials that are going on. I'll name them as well in the course of this talk. I'll try to share with you live cases which I have brought either from patients or some relevant radiological images which I received from patients in my hospital or other hospitals or journals, and I'll try to make it as up to date as we can, because that I believe is the biggest challenge. Because trust me, what I'm telling you now, 2 years later when you hear this recording, most of the things may have changed by then. So what is important is to make sure that we are up to date with what we have right now, and we can gradually build on that. So I just give a huge call out to all my juniors who are right now in this field or wanting to take up medicine or neurology or neuropsychiatry in the future. Please do align yourself to research because this is one segment where personally I as a doctor I can tell you this, that I have always been such a person who wants to leave something behind for my future generations to come and work on. So I wish we can all do that because that could leave a mark what we are trying to do, and especially in these domains where not a lot of options are available right now. So that's the major intro part. Another thing that I'll tell you for today, it will be glad and kind of you if you all can sit with a piece of paper, because not everything that is written in the slide will be dictated by me. I'm not a person who loves dictating slides. So there will be many things in the slides which I mean many things which I'll say which you may not find in the slides. So take a note of that, because I'm wanting to keep it very interactive, where you are also actively writing down things, because I feel that is something which improves memory. And when we talk of memory, memory is something which is one of the major domains of a neurocognitive disorder. So let's try and sharpen it up, and let's get pepped up as fast as we can. So yeah, Gagana, you can take over before if there's anything that you want to say, I can start off
Sure, sure.
right
Thank you
after
so
that.
much. Thanks a lot. Just give me a minute.
Just to confirm first with everyone, is my audio well well established enough? Can you hear me well?
Yes, yes, it is loud
Good,
and
good.
good evening to each and everyone. I'm thrilled to welcome you all for today's informative webinar on approach to neurocognitive disorders. I am Gagana Bellari, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today, Dr. Navanil Datta. Dr. Navanil Datta, MBBS, holds a fellowship in cardiology and is currently pursuing a DNB pulmonology. He has experience working at Columbia Asia Hospital, Kolkata, now Manipal Hospital, and has been actively teaching, moderating, and conducting seminars since 2022. A member of the West Bengal Rheumatology Association, Dr. Datta regularly attends CMEs and seminars nationwide. During his MBBS, he was part of SAMSA, South Asian Medical Students Association, contributing to student conferences from 2017 to 2021. In 2019, he was awarded Best Poster Case Presentation at the International Undergraduate Conference, Connaissance 2019, at JIPMER, Pondicherry. Thank you. Over to you.
Thank you, Gagana, and I I once again thank all the ones who have joined after I started saying a few things, and I'll be sharing my screen from now. From now, you won't be able to see me, but you'll be able to see a lot of things that I will be writing on the screen. I'll be highlighting the important parts so that it becomes easier for you to follow and later relate to. I hope we can enjoy this journey together, and we can learn something out of it. Anything which which you find doubtful, anything which you want to clarify, I'd want you to write in the chat box, and trust me, I'm going to cater to each one of those questions to the best of my knowledge. I'm going to answer and try to help you out with whatever doubts you're having. Mm, Before I start this, I want to thank uh, first of all, people who have supported me throughout this journey. There are a lot of people, and when I say a lot of people, I mean my teachers predominantly. A few very special people in my life who have always given me that boost in times when I needed, and have always told me that I do have a mentor somewhere in me. So thank you so much for that, and a big shout out to all the caregivers, especially of patients with neurocognitive disorders, because I am very closely related with one of them. Of course, I won't name that person right here, but that person is right now here. One is one amongst you all who's attending this, and a big shout out to all the caregivers of all the patients. I do not know if the others who are attending here have any of your relatives or anyone in your home who is who has been diagnosed with a neurocognitive disorder, and a big shout out and a big heart to all of you, because it takes a lot, and I wish we can somehow learn something through this journey. I wish I can motivate you. I wish I can light a spark in you somewhere so that you can take this forward. Maybe something which is miles better than what I'm doing today. So lots of love to all of you. And I'll be sharing my screen right now, and I hope you all can follow from there. So let's take this journey up. So This is the PDF or the presentation. I would request everyone to please be on mute. And if there's anything important which you are to attend, please be on mute. It's a personal request from my end. And yes, when we talk of neurocognitive disorders, the first thing that I want to tell you is what is something where I mean minor cognitive impairment versus major cognitive impairment. When I talk of minor cognitive impairment per se, I am meaning that uh, basic activities of daily life. What do I mean by basic activities of daily life? Or let's say basically when I talk of activities of daily life, there are two types of activities. One is the basic activities of daily life. The second one is the instrumental activities of daily life. Basic activities of daily life include the very basic core things that we do, getting up, brushing your teeth, dressing, cooking, and all the basic things that we do, combing our hair. These are basic activities of daily life. The instrumental activities of daily life are what we do professionally, like driving, like going to school, teaching. All of this account for the instrumental activities of daily life. So whenever I am talking of a mild cognitive impairment, or a minor cognitive impairment, I predominantly mean that the activities of daily life are going to be unaffected. So anytime there is no impairment in activities of daily life, that I call as ADL, or instrumental activities of daily life as IADL, this is what I will predominantly call as a minor neurocognitive disorder, or in other words, a mild cognitive impairment. Whereas if these are involved, then that is what leads us to the topic that we are discussing today. That's a major neurocognitive disorder, earlier also known as dementia, but now with the years, with the ranks, this term dementia is gradually moving a little out of context. We are replacing it with this umbrella term called the major cognitive disorders, neurocognitive disorders. Now, when I talk of dementia, or whenever I'm talking of a major neurocognitive disorder, what am I meaning by this word cognition? So, anytime I say a dementia or a major NCD, I'm meaning that yes, there is a major cognitive impairment, which means the activities of daily life are being impaired. Along with this, more than equal to one of the cognitive domains are being affected. More than equal to one out of the cognitive domains that I'll be talking of will be affected. What are these predominant six cognitive domains that I'll talk of? First is episodic memory. The second is language. Third is your executive functions. Fourth is social cognition, or let's say emotions for that matter. The next one is complex attention. And last but not the least is a perceptual motor function. As I said, there will be certain things in this slide which is not written. I would advise you to write along with, and that's why I'm maintaining a very, very decent pace. So, what I want to tell you is when I talk of cognition or a cognitive domain, I'm predominantly meaning six underlying things. First is episodic memory, the second is language, third is complex attention, the fourth is executive function, the fifth is social cognition, and the sixth is a perceptual motor action. What do I mean by all of this? I'll talk of memory in details in the next slide, but I'm not going right now there. Language, language is something where we have two parts to it. One is the comprehension, and the third is the ability to speak. It's like, I give you an example. There's a person who comes up to me and says, my name is Navonil, so people call me Neil out here. So if someone comes up to me and says, "Hi, Neil, I love you," first, if my ears are good, then I'm able to hear that, "Hi, Neil, I love you." There's a person who's coming to me and saying this, but am I understanding what is this person saying? Because if this same statement was told to me in Chinese, or in Japanese, I would definitely not be understanding, because I'm not aware of those languages. So first is comprehension, and that comprehension of language is something which is taken care by the vernix area of the brain, which is located in the superior temporal gyrus. Because I'm addressing to audience MBBS and post MBBS, I expect that you are well aware of these anatomies, and that the superior temporal gyrus, which is comprising of the vernix area, is actually what is helping me comprehend what is being said. So I can now understand, okay, this is English. There's a person who's coming up to me and saying, "Hey, Neil, I love you." Now, I can have a response to it. I can choose to have a response to it. That response may be a thank you. That response may be, "Oh, I'm pleased." That response may be an "I love you" back in return. It may be, "Hey, please don't disturb me with this." It can be either of these four, right? So based on my comprehension has to be intact first, that okay, I am being shown an emotion of love by a person. Based on this, my brain will process what reply I want to give, and I will ultimately speak out what I want to, or what I choose to. It may be anything. So that is taken care of by the Broca's area, which is located in the inferior frontal gyrus. So these are the basic parts of language that I want you to be aware of. Finally, coming to the next three domains, that is complex attention, executive function, and social cognition. What do I mean by complex attention? What is the difference between attention and concentration? Attention is something where where all your sensory stimuli are active right now. You are paying close heed to what I am saying. This is being attentive. What is concentration? When you have a sustained period of attention, that is what we call as a concentration. So when I talk of complex attention, it is about understanding that okay, there's a person right now by the name of Dr. Navonil who's taking a webinar, who's talking about neurocognitive disorders, is talking about what cognitive impairment is. This is being aware of what is happening. This is complex attention. Executive function, I mean things like how do I plan one thing? How do I plan one thing which leads to another? How do I plan a series of tasks, a series of events? Third being social cognition. What is social cognition? It's about realizing whether I'm in public space or I'm in a private space, realizing whether I'm in home or out of home, realizing how I need to behave. Of course, I cannot, behave like a child when I'm at the age of 20, 28 or 29. I cannot be behaving like a kid of 16, 17. I cannot be suddenly doing things which I did back when I was a toddler. So it's understanding all of this. And all of these three domains are something which is taken care of by the prefrontal cortex. So complex attention, executive functions, and social cognitions are taken care of by the prefrontal cortex. And trust me, we're going to have a very, very detailed, discussion on this prefrontal cortex in a while. And the last, which is perceptual motor functions, or what we in neurological terms call the famous praxicons, praxicons, praxicons. Praxicons are basically the formula of any movement. Like I tell you right now that it's winter. There's this person who came and told me that I love you. I want to go up to that lady and propose her back. So what will I do right now? Right now I'll have to get up from my chair. I'll have to go. I'll have to probably take a rose from a shop where flowers are being sold. I'll have to take a rose. I'll have to customize that according to how I want it in a bouquet or anything. I'll have to go to the lady. I'll have to initiate a conversation. I'll have to bend down on my knees. I'll have to ask that, okay, like, do you wish to marry me, or yes, I love you too, whatever it is. So this exact formula of this entire movement is what we call a praxicon. And whenever I'm telling you about a perceptual motor function or a praxicon, I'm typically meaning the superior parietal lobule. So these areas should be something which are very, very nicely embedded in our brain, because these areas and the functions and the effects, the effects of lesions in these areas will actually guide us as to how we take forward this webinar from now. So whenever I talk of cognitive domain, these are the six domains. Any one out of the six, I mean, any major cognitive impairment, that is an impairment in the activities of daily life, with greater than equal to one out of the six domains being affected, that is what leads me to a diagnosis of a major NCD or dementia. So that's the first part that I want to tell. Now, let me talk of the major part of dementia, because till a point of time for neurologists, dementia was equal to memory. Even I can tell you, for most of you right now, I'm very sure if I say dementia, the memory is the first thing that you'll think of. That okay, loss of memory is dementia. No, memory is one of the cognitive aspects of dementia. As I said, there are six cognitive aspects. Memory is just one of them, but definitely one of the most important parts. So when I talk of memory, let me see how I can divide memory. Till a certain point of time, in the 1900s, in the 1950s rather, there was this old classification that we used to follow, where we had immediate memory, which was more of a working memory. It was based on retrieval. Like I ask you all, what did you have in lunch today? It's basically retrieval, right? Like you can go back and think, okay, I had say rajma chawal, or I had butter chicken, I had tandoori chicken, anything of that sort. I had shahi paneer. So this is retrieval. And when I talk of retrieval, again, this major organ comes in, which is the prefrontal cortex. The second thing is what is short-term memory, and the short-term memory is concerned more with storage. Storage occurs in the hippocampus. So basically, based on based on how important the event in our life is, you know the memories are processed either as short term or long term. Let me give you an example. Like, say, I tell you, what did you have for lunch today? Most of you, 100% of you probably will be willingly able to answer me that, I had this, sir, for lunch. But if I ask you, what did you have for lunch, say, yesterday? Still, there'll be 90% people who will be able to tell me. I ask, what did you have for lunch 2 days back? Still, almost 60-70% of you will be able to tell me what you had for lunch 2 to 3 days back. But if I tell you right now, what did you have for lunch on the 10th of December 2024? Now, now there will only be maybe one, two, or maybe a very few number of people who will be able to correctly answer me. Now, why is that happening? So basically, once I ask you what you had for your lunch day before yesterday, or say yesterday, this is a short-term memory. This has been stored right now in the hippocampus. This short-term memory will gradually, if it's not important to you, and if it's not important to you means that's how the brain perceives. If it's not important to the brain, it will just move it to the recycle bin. It's just like a recycle bin of a computer. It just stays there. And after a point of time, just like every other trash is cleared, the recycle bin will clear its trash. But when I ask you, what did you have for lunch on 10th of December 2024, for maximum number of people for whom 10th of December was not a major date for that matter, they will not be able to say. They'll say, oh, I don't remember what I had for lunch on 10th of December. Even I don't remember. But maybe that one person in this group, maybe, who had his birthday on 10th of December, or maybe someone who had her anniversary on 10th of December, or maybe went out on a date with their significant other on the 10th of December, will be able to recall what they had, because that is now aided with emotions. Because that emotional component starts, because we consider 10th, because for that person, 10th December is a very significant date. For that person, 10th December is something which is memorable. Once it's a memorable date, based and considering its importance, the brain realizes that, okay, I need to now not send this to the recycle bin, but I need to now send this to the neocortex, where it will be stored for a longer time. So storage in short-term memory is hippocampus, storage in the long-term memory is neocortex. And anytime I'm talking of long-term memory, it will be stored in the neocortex. Whenever I need to retrieve it, like today, I will ask that girl or the boy, or anyone for that matter in this group, that what you had on 10th of December 2024, provided it was their anniversary or their date or their birthday, they'll be able to retrieve it. And this retrieval is again based on the prefrontal cortex. So till now, I have talked of prefrontal cortex in so many places. The first place where I talked of prefrontal cortex is the understanding of complex attention, executive functions, the social cognition. Along with it, in memory, which is one of the major domains of a cognitive domain, which is one of the major cognitive domains for that matter, immediate or working memory, it's by the prefrontal cortex. The retrieval of long-term memory is again by the prefrontal cortex. Now the point is, after 6 years, or say today, if I ask this guy whose birthday is on 10th of December, if I ask what he had 6 years back on his birthday in lunch, he will not be able to say. Why? Because 6 years is long enough a time for the brain to realize that, okay, it has been there in my memory for long. I don't need it that long to stay. So I will now send it to the recycle bin, following which, after a certain point of time, it'll be cleared off as trash. So that is exactly how memory, according to the older classification, is. The classification is somehow obsolete, but the structures still remain the same. When I talk of newer classification, I'm going to basically have two types of classification. One is the explicit memory, which is also called the declarative memory. Under declarative memory, I will have episodic memory and semantic memory. What do I mean by episodic memory? It's mainly the time and context-based memories that we have. For example, uh, mm, suppose I have a patient, I have my father at my home who who is a patient of Alzheimer's. And why am I talking of Alzheimer's right now here? Because episodic memory is the first memory that is affected in Alzheimer's, basically. So I'm just trying to give you an example of a patient of Alzheimer's who would basically have an impairment in episodic memory, and how the impairment would happen. So imagine my father, who has been diagnosed with Alzheimer's, say, a year back. He he was well off till a year back. Since the last 1 year, he's been treated for Alzheimer's. And he meets today one of my friends, who is a very, very old school friend of mine. He has seen that friend of mine multiple times. And uh, that friend today has come to my home. My father is able to recognize my friend because he has been seeing this person for a very long time. So this is not an episodic memory. This is something which is a long-term memory. It is there intact in my father. He recognizes my friend. For example, let's name him Rahul. So he says, "Hi Rahul, how are you?" Rahul says that, "I'm fine, uncle. I've come here to invite you to my wedding." So my father hears wedding. He immediately says, "Wow, congratulations! I'll definitely attend." Now my father attends this wedding with me. It's my friend's wedding. My friend whom he has known for the last 30 years. Rahul's wedding on, say, the 14th of February. My father attends the wedding, and now he's meeting Rahul's wife for the first time. In the last 30 years, he has never known Rahul's wife. He knows Rahul. He knows me. He knows Rahul is my friend, but he's not aware of Rahul's wife. So Rahul's wife he meets, he congratulates, and naturally he comes back from the wedding. After 3 or 4 months, Rahul makes a visit to my home again. So February is 3 months ahead, which is like May or April, June for that matter. On 14 June, Rahul makes another visit to my home with his wife. Now my father, who has been diagnosed with Alzheimer's since a year and now being treated, he cannot recognize Rahul's wife. Now Rahul is continuously trying to tell me and my dad that, "Uncle, you came to our wedding. You remember I had come for my wedding invitation. You came to my wedding. You enjoyed a lot. You ate to your heart's content. You blessed both of us. How is it that you don't remember?" So post the diagnosis of Alzheimer's, whatever new memories were starting to be formed, that has completely been impaired. Now, Rahul will remain in my father's memory, but Rahul's wife will not. This is a typical example of how an Alzheimer's dementia presents, a typical example of how autobiographical memory and episodic memory, for that fact, is impaired early in stages of Alzheimer's disease. So, not remembering new persons, new memories, new facts, all of this is episodic, and this is taken care of by the hippocampus. When I talk of semantic is more of fact based. It's like, when did India gain independence? Who is the father of the nation? And trust me, all of this people don't usually forget. So this is something which is hardly ever affected in any neurocognitive disorder. Alzheimer's patients have hardly, any impairment in this, because I've come across Alzheimer's patients who would be very easily able to recognize Mahatma Gandhi by, if a picture of him is shown, or a Subhash Chandra Bose for that matter, or asked about when did India gain independence, when is the Republic Day of the country, they'll be easily able to tell the dates, because this memory is more about the involvement of the association areas, the parieto-occipital association areas, the temporoparietal association areas, the occipitotemporal association areas. These are the predominant areas which take care of the fact-based memories, and these are hardly or maybe very late affected in Alzheimer's, in the very later course of the disease. When I talk of implicit memory comes with four domains. First is a procedural memory. Procedural memory is taken care by predominantly the subcortical structures, mainly the basal ganglia, the cerebellum, and one cortical structure, which is the supplementary motor area. What do I mean by a procedural memory? So suppose I tell you, what is the procedure to drive a car? Imagine when you first go to a driving school, you are taught the basic steps first orally, right? Like, you get into the car, adjust the seat, wear the seat belt, put the gear in neutral position, press the clutch. Clutch is on the left side. Press the clutch, make the gear, adjust the pace of the car, adjust the accelerator and the brake, and that is how you move the car. Now, initially, you learn this orally. Then, with time, by the fifth or the sixth session in the driving class, you are so well acquainted with this that you do not need to, orally remember the steps. You will immediately get into the car, and you will sit on the seat, and it's just like muscle memory. It just seems like everything is so smooth for you, which is why the same thing happens with cycling, the same thing happens with swimming. So these are all procedural memories, which is very properly processed in the subcortical structures of our brain, like basal ganglia, cerebellum, and a bit of cortical involvement. That's the supplementary motor area, which plans and coordinates how the muscles will move according to that movement. Like, as of now, when you are sitting in the seat, you have to move your arms to adjust the seat belt, you have to move your legs to press the clutch, the hands to neutralize the gear positions. All of this is something which is done by the supplementary motor area. The second one is priming. Priming is something which I can give you a funny example. It's basically based on exposure, and it's taken care of by the neocortex. If you just recall, a while back I was talking of neocortex in storage of long-term memories. So what do I mean by neocortical priming? I predominantly mean, suppose you've gone for an interview to a company, and there's a long queue of candidates who are sitting there, and you have just been called by the peon or the clerk who's there managing the names of the candidates who have been attending this. And what happens is, so the peon has called out your name. You're walking with the peon through a corridor which leads to the interview room. You're moving there. On the way, you're asking the peon that, okay, like how's the paper, or how's the interviewer, is he good, is the company good, and all of this. So imagine if you did not get a job after this, you would virtually forget the peon. Trust me, you would not remember this peon. But if you get a job in this company after the interview, you're going to remember this peon, the conversations that you had with him for a very, very long time. And uh, even if you leave this company after say 5 6 years, you are still going to remember this peon, because you will, whenever you think of this company, you'll be immediately drawn to that day when you cleared the interview. You will be immediately drawn to the conversation that you had with people before you cleared the interview. So that is more on exposure. I can give you a similar example. Suppose this very peon is a lunatic and he slaps you before you get to the interview. Any nonsense reason, he just gives you a slap. You'll be remembering that, oh my god, I met such a rude person there. So it's more about exposure. It's more about emotional, mixed with emotions that we have towards that memory. And that is how that is what we call priming, which is taken care of by the neocortex. When I talk of associative memory, I'm predominantly meaning the amygdala. And this form of memory is not actually present in humans. It's present in animals. And amygdala is basically a fear and a rage center. So in animals, a deer, a deer in its group will always be afraid that anytime a lion can pop up from somewhere and try to kill my babies, or a tiger can pop out from somewhere and try to kill me. So this fear, the consistent fear that animals have about being attacked, about being killed, is something which contributes to the associative memory. How that works for them is, you will often find, when you watch these videos or the documentaries in wildlife on National Geographic or Animal Planet or Discovery for that matter, you'll see how these deers, they will sense the climate changes, they will sense the smell of a lion in the air, and they will automatically have their heels on their toes. So they will automatically be in a stage where they will be able to flee. They'll have this fear at the back of the head, that they might be attacked. This is usually not present in humans. And the non-associative memory is what we call as the reflex pathway. It's more of a habitual response. Like, imagine the first time that you ever were scolded in your school, or say, for my juniors, imagine the first time that you were called out in front of a class, in front of everybody, and you were told, please leave the class. You have presented a horrible case. That day, you can remember how bad you felt. But trust me, following that, after every viva, on every viva day, it becomes like a norm. You are going to be thrashed by the invigilator. You are going to be thrashed by your senior. You are going to be scolded. So that becomes such of a much of a habit now. So what happens is, you'll find first year medical students being so serious during their first semester or their first internal examinations. They're all serious. One of them is crying when the professor is scolded. By the second or the third year, they are laughing. But even if they have given a horrendous exams, they are laughing, because it's become much of a habitual response that has come to them. So this is a non-associative memory, which is taken care of due to the reflex pathways, which develops due to habits that we associate with the memory, that or events that are occurring. So that is a brief, and a very, very brief, as well as a very detailed explanation of memory that I could give you. Before I move into the next slide, I'll switch my video on, and I would once want to know if there's any doubt that you all have regarding what I have taught till now, because the next part of this conversation becomes valid only if you have understood what I have told till now. I'm doing this specifically for this session because it is a very, very difficult domain. So I will leave the chat box open for around 5 minutes, for anyone to drop in whatever questions you have till now, on till now, whatever we have discussed. So you're open to write to me anything that you want. I'll be giving you around 3 minutes. You can type your queries. If there's anything that you want to write to me, If there are no doubts, then we can move ahead. But I'll be surprised if there are no doubts, to be honest. Okay, so there is a question. I'm not able to read out your name. Forgive me for that. Hey, doctor, what causes a person to forget things easily? Okay, so yeah, again, uh, okay. So if you're talking for a normal person, I'm glad that you raised this doubt up. So that's why I was saying that I'll be surprised if there's no doubts. So for a normal person who's not having a neurocognitive disorders, why do we forget? So let's take studies. Okay, why do we forget studies? Uh, why do we forget studies, but we don't forget films? Why do we forget studies, but we don't forget songs? I've seen people in concert. The singer has forgotten the lyrics. The audience is queuing him or her and singing out the right lyrics. But the same person comes and says, "Yeah, gosh, I had this memory for my studies." The problem is, if you remember, I was talking about short-term memory and long-term memory, and I said based on what the brain feels is important, it will keep it stored in the neocortex. Otherwise, it will send it to the recycle bin where it will be treated as trash. Uh, so what happens is when we are studying a topic, we are never revisiting that topic again. Like today, if I'm taking this session on neurocognitive disorders, and if this is the last time that you're watching this, you will be able to retrieve a lot of this tonight, even tomorrow morning. But trust me, after 5 days, it won't, because the brain knows ki, since you have never revisited this video again, since you have not revisited what I'm telling you, it will consider that okay, it's not important. It will be moved to your recycle bin. And if you don't revise, say, in the next 10-15 days, it will be thrown away. After a year, if you watch this video, it will just seem like you're seeing me for the first time. So, or you're hearing my content for the first time. But you know what? The same does not happen with the film, because when we watch a film, when we hear a song, we associate it with emotions. Suppose we are hearing a love song and we are thinking of our significant other, or we are thinking of a fantasy world with that person. So that is what makes us not forget them, but forget these. And that is why it is said that the only way that you can make studies worth being in your memories, by revisiting them. And it is always said that there are two ways that you can not forget studies. Number one is by revisions. Number two is by solving questions, because when you solve questions, your brain actually understands that, oh, I read a plus b ka whole square is a square plus 2ab plus b square. Now I solve a question which says, find out what is the value of 7 plus 4 ka whole square. So now you know, okay, 7 plus 4 ka whole square is 7 square plus 4 square plus 2 into 7 into 4. This application part, that is what makes the brain realize that, okay, this is important. I don't need to push it to the recycle bin and trash. I need to keep it to the neocortex. And whenever a question like this comes up again, my prefrontal cortex is going to quickly come up and retrieve that memory. So that is one part. And the second thing is, it's always said, whatever you study, I'm telling this to all my juniors, whatever you study, teach it to someone, teach it to anyone. If possible, if you don't have a human being, teach it to your pet. Kuch nahi, just go in front of that person and blabber it out. It's the best way that you can remember something. Trust me on this. I can tell you, I am one live example of this, because right now I have this audience to cater to. Once upon a time I didn't. I used to sit in front of the mirror and I used to talk to the mirror as if it's me teaching another version of me. There were times when I used to call my mom up. There are times when I used to call my grab hold of my sister, or in my college I used to grab hold of any junior and say, "Oh, sit here. I'll teach you this topic." So teaching is the best thing, because when you teach, you realize that okay, this is one way that I can approach the topic. That you get doubts, that is what enhances your skills as well, which is why I want this session to be a very interactive session, because that would help me also as a person to grow and be a better learner. And I think that is what our aim is to be at the end of the day. So I hope that doubt is cleared. uh, there's something called a certificate link. I'm not very aware of this, trust me. You have to talk to the team. I presume there are no more doubts regarding this, so I will move ahead. Thank you for the question. Sorry, I don't know your name, but really thank you for your question. Okay, there's a question that has come up. Sir, like if a person has some psychiatric condition, like depression or some other, the patient may forget things for a while. Okay, yeah. So this is another good question, and I'm telling you, you will get the answer to this in the next 5 minutes. So the next slide that I'll take you over to is going to answer this question regarding the psychiatric disorders and their association with forgetting. I'll just tell one line before I begin that. So depression is actually considered as pseudo dementia. What do I mean by pseudo dementia? It's actually a condition where this patient will not actually lose his memory. It's just for a very short period of time. Once the depression goes away, once that is catered, the the cognitive function starts improving, the dementia and the memory losses and the other things actually start getting back. So that is more of a psychiatric thing. It's because of the reduced level of the neurotransmitters that happen in the brain, like especially serotonin, which has a huge effect on mood and cognition. So depression is actually one of the causes of pseudo dementia. In fact, I'll tell you in a while that once I have to label a patient of neurocognitive disorder or dementia per se, I'll have to rule out whether there are other causes of pseudo dementia, whether there are any reversible causes of dementia, or whether there is any psychiatric association or a pseudo dementia. That is something which I'll have to rule out first before I can call this patient a proper patient of neurocognitive disorders. A few more questions. Good to see. Good to see interactive audiences. My name is Solomon Noel Gomes. Hi, Solomon. That was a lovely question from you. Sir, a patient suffering from bipolar disorder, what is the reason for that? See, this topic is not about bipolar disorders, my friend. But I can only tell you this, that bipolar disorders or psychiatric disorders are not our topic of interest today. We are specifically focusing on neurocognitive disorders. But if you ask me why bipolar disorders occur, it's again it's excess of serotonin, it's excess of acetylcholine, excess of dopamine in the brain, which causes features of psychosis and mania in these patients, and a reduced level of glutamate in the brain, which leads to features of depression. So it's concurrent mania and depression occurring in the same patient. That's what we call as bipolar. So I think no more pertinent doubts, because now I'll have to move on to the next section of my webinar. That will be right here. I hope you all can see this page. So yes, this is the slide which answers a lot of your questions, which had come up a while back. But before I deal with the larger part of the slide, which I won't right now, I will only deal with this particular segment. Why I won't deal with the other part of the slide is because once you have an idea of the different types of dementia, we will all come back and revise from this one flowchart, because I think that is going to help you a lot. So I will not make it like spoon feeding. I'll rather discuss only this one particular box, which says the reversible causes of dementia. As I said, whenever I talk of dementia or a neurocognitive disorder, there has to be a cognitive impairment, a major cognitive impairment, which means there should be an impairment of activities of daily life. Along with it, at least one out of the 6 domains that I talked of, there has to be an impairment in at least one out of those 6 domains. So before I call a patient of neurocognitive disorder, I should first rule out whether there is any reversible causes of dementia, and the mnemonic for it is dementia as well. It's the same spelling, DEMENTIA. D for drugs, anticholinergic drugs, specifically, cause dementia, because it's not written in this slide, but you can write this down, that acetylcholine is such an important neurotransmitter when it comes to cognition. Its major source is the nucleus basalis of Maynard, MEYNERT. That's the nucleus basalis of Maynard. That is exactly from where in the brain acetylcholine is released. And acetylcholine is something which helps us in wakefulness. It helps us in cognition. It helps us in memory. There's just so much of good work that acetylcholine does. And once these pathways are damaged, maybe due to any degenerative disease, or say drugs right now in this case, like anticholinergic drugs, they will definitely affect the cognition. The second one is benzodiazepines. Most elderly Indians have this unwritten rule of having one benzodiazepine and going to bed at night, and then after a point of time they don't feel sleepy, so they start increasing the dose. But what happens is they do get a lot of sleep, but at the end of the day, the next morning when they wake up, they feel that their brain fogged. So benzodiazepines are another group of drugs which lead to a picture which is similar to dementia, but then again it's a reversible cause, so we will never call this as a neurocognitive disorder. Next is opioids like morphine. They are depressants of the brain. In fact, they depress all the centers. They are serious depressants. They are respiratory depressants. They depress your cognitive function, wakefulness, memory, awareness, judgment, abstract thinking. Everything is depressed. So that is all about opioids. When I talk of emotional, E for emotional, that is depression. As I said, depression is a cause of pseudo dementia. You should always rule out depression as a primary psychiatric evaluation in a patient whom you are diagnosing as major neurocognitive disorder. When I say this, I will also say this, that yes, most patients who are a patient of neurocognitive disorders do show psychiatric manifestations of depression, but in them, depression is never the primary diagnosis. If depression is the primary diagnosis, you can never consider this patient as a patient of major neurocognitive disorder. Next is M for metabolic. Any end organ dysfunctions, the electrolyte abnormalities, specifically hyponatremia, never hypokalemia. I found many of my juniors at times, wrongly saying hypokalemia. There's a famous line which says sodium stabs the heart and sodium stabs the brain and potassium stabs the heart. So never ever say hypokalemia as a cause of brain dysfunction. It's always hyponatremia. Sodium always attacks the brain and potassium stabs the heart. A low potassium, high potassium, always stabs the heart. I often tell this to my juniors that sodium is like the professor, who is behind you for submitting all the papers, and potassium is like a girlfriend. It'll always stab you. So that's exactly what we mean by the hyponatremia causing a metabolic abnormality, where the patient presents very much like in a state of delirium. You'll find most elderly patients, after a bout of vomiting, a few bouts of vomiting, or say elderly patients who are on diuretics for that matter, and they have not been monitored well for their electrolytes, they will suddenly land up in your ICU with an acute confused state, and you'll be thinking that, okay, is this dementia? No, it's not dementia. It's completely a case of altered mental status, which can be very easily reversible. You correct the fluid, you give fluids, you correct the sodium, and everything is corrected. E for endocrine, hypothyroidism, hyperparathyroidism, and Cushing's. Cushing's is something which I'll tell you to keep in mind. And for nutritional, where there is B12 deficiency, again, it's a very reversible cause. T for trauma, tumor. By trauma, I mean chronic SDH. So, micro bleeds, micro infarcts, or micro hemorrhages for that matter, are something which in the long run, especially in older people, because beyond 50, I always say this, beyond 50, any major head hit in the head, any major hit in the head, even if it's with a wall that is just adjacent to your bed, you should be careful. You should observe for the signs and symptoms, because you do not know, you can always have a chronic SDH developing. I for infections, and in infections, the two major infections that I'll tell you are HIV and syphilis. So you need to screen these patients up. HIV, you'll be doing the assays, the PCR assays, and the HIV antigen tests. And for syphilis, you can always do a VDRL or an RPR. And A for apnea and alcohol. So in apnea, I predominantly mean the obstructive sleep apnea, and alcohol is something where alcohol-related issues we'll be talking in the next slide, where we'll talk of how alcohol impairs your awareness and everything. So what I mean, these are the reversible causes of dementia, and before you classify any patient as a patient of neurocognitive disorders, you have to rule each one of these segments out through proper history, through proper investigations, and of course through proper imaging, if and as and when it's required. So that's all about the reversible causes. As I said, I'll come to this slide in the very end. I'll quickly take up this alcohol-related issues, because it's a very, very simple topic to take up. So alcohol can either present, alcohol-related issues can either be acute, it can be chronic. I'll talk of the acute state first. Excessive alcohol intake that leads to a confusional state, and so either this patient can come with a case of an alcohol withdrawal. And what do you mean by a withdrawal state? This person has been a binge alcohol drinker all his life. Suddenly, since the last 2 days or the last few hours, he has not been, having alcohol. So he comes if the presentation is between 6 to 48 hours, there are minor symptoms like tremors, anxiety, there's headaches. HA's headaches, and the treatment is something which is very simple. It's like you give chlordiazepam oxide, and you can treat any minor acute withdrawal syndrome. Uh, if this patient is presenting between 12 to 36 hours, then you can have seizures. These seizures is predominantly GTCS. So again, when the treatment of choice is either by giving diazepam or lorazepam, and if you know this, lorazepam is safe in liver failure, and after the period of 36 hours, when it progresses from 36 to 48 hours and even beyond, that is exactly when visual hallucinations start to set in, because the temporal lobe now starts getting involved. And beyond 48 hours, I mean, anytime you find an alcoholic who is coming to you with altered mental status, hallucinations, and the period of withdrawal is something beyond 48 hours, always think of this term, which is DT, that is delirium tremors. And you'll have this patient who's in agitation, there'll be tremors, there'll be altered mental status, the heart rate will be high, the patient will complain of a pounding sensation in his chest, there'll be sweating, there'll be high BP. So all the sympathetic systems will be activated. And this is the time when you need to treat this patient on a very priority basis. You need to give thiamine followed by dextrose. Always remember, it's thiamine followed by dextrose. For the reason why thiamine given before dextrose, please go back to your biochemistry lessons, where if you give dextrose earlier, because the alcoholic patient is already in a state of chronic malnutrition, what happens is the excess of glucose that you give is now shunted into glycolysis, and it forms lactic acid. So lactic acidosis happens if you don't give thiamine first. Also, thiamine is something which will replenish the enzymes which are involved in the glucose metabolisms. The second thing that you need to take care of in these patients is you will gradually give them gradual feeds, because you can understand a patient who has been a binge drinker, has not been drinking since the last 2 3 days, presenting to you with seizures, with agitation, altered mental status. This is the time when you gradually need to introduce feeds. So do not give feeds, the total calories right on the first day. Divide it and gradually increase the number of calories, because otherwise you would be landing up in another critical state, which is called a refeeding syndrome. In this refeeding syndrome, the only one electrolyte lab parameter which is the path driver, let's say, for refeeding syndrome is a low phosphate levels. So anytime there's low phosphate levels, that triggers out a cascade of other reactions, where you'll have hyperkalemia, you'll have hypomagnesemia, you'll have hyponatremia, and all of these electrolyte abnormalities will start coming in. There'll be arrhythmias that will be setting in, there'll be hyperglycemia, there'll be hyperinsulinemia, and all of these things will start setting in refeeding syndrome. So anytime a patient of delirium tremens is coming to you, always give thiamine followed by dextrose. Take care of refeeding syndrome, give calories gradually in increasing amounts. The other type that can present in acute intoxication is a Wernicke's encephalopathy, and it's a triad. Basically, we call it the COAT triad, COAT, where we say, C for confusion, and ophthalmoplegia is O for ophthalmoplegia, and A for ataxia, and T is the triad of this. So that's a COAT mnemonic: COAT, confusion, ophthalmoplegia, ataxia. The treatment is again thiamine, and if it's asked what is the first symptom that responds to thiamine, it is ophthalmoplegia. The second thing to resolve with thiamine is ataxia. And the third thing to resolve with thiamine is confusion. So that is what I want you to remember. Most common cranial nerve that is involved is the sixth cranial nerve. It's a bilateral cranial sixth nerve palsy, which is a bilateral lateral rectus palsy. The patient will not be able to look to the two lateral sides. That is one manifestation. And most common ophthalmoplegic manifestation is nystagmus. As I said, it's the first thing to resolve with thiamine. In a chronic intoxication, the patient can predominantly have neuropathy, which may be an axonal form of neuropathy, or this patient can come to you in a typical form, which is also called the KAS, or the Korsakoff amnestic syndrome, where there is amnesia, there's confabulation. What do I mean by amnesia? It's both an anterograde and a retrograde amnesia. Means the patient can't remember anything new, the patient can't remember anything old. But as I said, is this dementia? No. Is this neurocognitive disorder? No, because it's a reversible cause. Anytime I'm dealing with a reversible cause, I cannot call this as a neurocognitive disorder. So what is this? Is amnesia, both anterograde and retrograde. What is confabulation? Confabulation means this patient will not be able to remember certain segments of the memory, and will hence try to fill in with certain gibberish stories, which in simple terms we will say that the patient is lying. But the patient is not willfully lying. The patient is lying and he's not aware of it. He's trying to fill up those gaps in his memory with gibberish. So you can ask him that, what made you come to the hospital? He'll say, uh, I don't remember, but I think I was there in a marriage party, and I think I was climbing down the stairs and I suddenly fell down. All of this is rubbish, because he's in this hospital because he's having a case of alcohol withdrawal. So he does not remember it. And the example that he gives about being in a marriage party and falling down the stairs, it's not a lie. It's actually confabulation, where he's filling up these gaps in memory with gibberish statements. As I said, the amnesia is anterograde and retrograde, and this is one thing which is irreversible. So that is exactly what I want to say you, that confusion, which happens in an acute setting of alcohol intoxication, is something which is reversible with thiamine. But in a Korsakoff, it is completely irreversible. There's a very famous line which says that administration of thiamine will, mask the Wernicke's and unmask the Korsakoff. I mean, if there's an acute on chronic alcohol intoxication, the warnings will be treated with the confusion of warnings will be treated with thiamine, but the amnesia which is there in Korsakoff will not be treated by thiamine. So that is something which I want you to know. These are predominantly the alcohol related issues. Before I move to anything, I will now tell you that before I move to the main flowchart which I was talking of, I'll start off with the predominant section of major neurocognitive disorders. And when I talk of major neurocognitive disorders, I'll talk of the most common neurocognitive disorder that we have in the world today, also in our country, and that is Alzheimer's disease. And before I start Alzheimer's, I would again want you all to post whatever doubts you have, because Alzheimer's, post Alzheimer's, again, there'll be a little doubt session, and then I'll move on to the other sections, because these are very, very, very sensitive topics, very, very interesting topics, and I want you to be clear with whatever you're saying. I hope the reversible causes and the alcohol related issues are clear to you. Before I move to Alzheimer's, I take up doubts for the next 2 to 3 minutes, post which I'll move on to Alzheimer's. You can post your questions. I think there are a few questions. There's one question. Are neurocognitive disorders genetic? Yes, they are, my friend. There are many, there are huge spaces of genetics in neurocognitive disorders. I will talk about them when I talk of the individual neurocognitive disorders. There are many, many disorders which are genetic, of course. And the one that I'll start with, Alzheimer's, has got a good amount of genetic predisposition, definitely. So any doubts I would entertain. Next 2 minutes. You can ask me anything about whatever we've learned till now, and I hope you're enjoying this class. I hope that you're able to keep in pace with what I'm saying. As I said, it's a difficult topic, which is why I'm going a little slow. Thank you so much. I'm not able to read out your name. It's Shishpal. Thank you. Thank you so much. What is the first stage of alcohol dementia? Okay. So alcohol dementia, again, I don't know why you're saying alcohol is dementia. As I said, alcohol is not dementia, my dear. Dementia is something which is a major neurocognitive disorder. Alcohol is just a reversible cause of dementia, and hence cannot be, properly called as dementia. But the first sign of alcohol withdrawal is something, as I said, it just comes with tremors. It comes with headache. It comes with a brain fogginess. It progresses gradually to seizures, then progresses to hallucinations. And this stage where there are seizures and hallucinations occurring, if it's a period more than 40 to 72 hours of withdrawal, that is what you call as delirium tremens. So that is exactly what it is. Do I have any more questions? Otherwise, I will start off role of yoga in cognitive disorder. Okay. Okay. So yeah, yoga and exercises, they have been shown to delay the progression or the onset of neurocognitive disorders. I'm especially talking of things like Alzheimer's, because as I said, it's the most important neurocognitive disorder and the most common one that we have in the world right now. So it is said that a healthier lifestyle, exercise, engaging in tasks which are very actively involved with the brain, making our brain work in certain mental exercises, physical exercises like walking, running, cardio, high intensity exercises, they have shown a benefit in delaying the onset. But if you ask me for treatment, no, not at all, my friend. They can of course keep your other organs well, definitely, but they cannot improve your current status that you have in once you're diagnosed with, say if you're diagnosed with Alzheimer's. I cannot tell you that yoga and exercise is going to cure you out. That's not going to happen. It can delay its progression. It can, if you do not have a family history, then if you keep being that physically active and fit, it can delay the onset, or it can probably never make you have it. But once you have it, no, my friend, that's not something which is going to help you. Are neurocognitive disorders reversible? No, neurocognitive disorders are not reversible. I've already discussed the reversible causes. Those reversible causes are reversible. Like if I'm talking of hypothyroidism, if I'm talking of a hyponatremia, if I'm talking of alcohol, of course, alcohol is on you. I mean, if you decide to leave alcohol, it is reversible. But once the reversible causes are ruled out, the other thing is not something which can be reversed. So that's all. I think I can take up that many number of questions as of now, because then I'll be moving on to the crux of the day, that is Alzheimer's disease. So welcome to this journey now, because from now things get a little tricky. So I hope you can maintain the pace with it. Okay. So now I take you per se to this whole journey of Alzheimer's. And when I talk of Alzheimer's, I will clearly tell you one thing, that it is definitely the most common cause of dementia and the single most important risk factor. If there's one risk factor that I have to say, it's age. Uh, Older age, higher the age, higher is the risk of Alzheimer's. In fact, it says a patient more than 85 years has at least 40% chances of developing into Alzheimer's. I'm not talking of the people who are having a positive family history. In them, the age starts, the age in subsequent generations starts to decrease. But I'm talking for people who do not have a positive family history. In those patients without a proper genetic mutation that has been established, Alzheimer's, the highest risk, the most important risk factor is age. Uh, Most of the cases are sporadic, but some do have a genetic basis. Now, what is this Alzheimer's basically? What do I mean what do I mean when I talk of Alzheimer's? So predominantly, uh, it's basically nothing but a form of an amyloid deposition. I just want to add a page here. I don't know if it's visible. Let me see. Be good if I can add a page. Yes, I guess I can. Yeah. So So whenever I'm talking of Alzheimer's, I'm predominantly going to talk of a few elements, which I will write it down also in the process. I hope you can bear with my handwriting. Uh, just a minute. Yes. So whenever I'm talking of Alzheimer's, I'm predominantly talking this one basic protein, which is the APP protein. What is this APP protein? It is the amyloid precursor protein. And this amyloid precursor protein, it's having a gene which is located on the chromosome number 21. And normally this APP is something which is involved in normal neuronal function, normal axonal transport, normal electrical activity across the neuronal synapses. But because it's a gene, it will encode for a protein. That protein will be usually, it will be degraded by an enzyme called alpha secretase. So this enzyme alpha secretase will normally degrade the APP. Now, what is going to happen? What is going to happen in case of Alzheimer's? In case of Alzheimer's, this APP will, instead of being metabolized by the alpha secretase, now it will be metabolized by beta secretase. Instead of being metabolized by alpha, it will now be metabolized by beta secretase. What is happening? Because of being metabolized by the beta secretase, this will now start accumulating into abnormal protein aggregates, into abnormal protein, sorry, will start accumulating into abnormal protein aggregates. Abnormal aggregates, and we know what are abnormal aggregates of proteins usually called, which are arranged in beta pleated configurations. They are called amyloid. This amyloid aggregation, which is also called the A beta form of amyloid, which is, as I said, it's arranged in the beta pleated sheets. So A beta amyloid is being produced. And why is this A beta amyloid being produced? It is being produced because of the abnormal metabolism of APP, which is uh, which is coding a protein present on, the gene is present on chromosome number 21. Its abnormal metabolism via beta secretase enzyme is leading to abnormal aggregations of beta pleated sheets, which is also called A beta amyloid. How many A beta amyloid do we know? One is A beta 40, the other is A beta 42. Why am I talking of this? When I talk of Alzheimer's, I am predominantly meaning the A beta 42 subtype. This is what is involved in AD, that is Alzheimer's disease. And when I talk of A beta 40, it's nothing but a certain disease which we'll read later, which is called cerebral amyloid angiopathy. Cerebral amyloid angiopathy, also called CAA. So, in a nutshell, APP, abnormal metabolism by beta secretase, leads to abnormal aggregates of amyloid called A beta. two varieties, A beta 40, A beta 42. The 42 one is what gets accumulated in Alzheimer's disease, and the 41 is what gets accumulated in a disease called cerebral amyloid angiopathy. And this A beta 42, which is found in Alzheimer's disease, what happens with time is there will be what happens with time is there is gradual deposition. There's a gradual deposition of these A beta 42s, and along with it joins phosphate. Whenever there is a phosphorylation of these A beta 42, that is what we call as hyperphosphorylated hyperphosphorylated tau proteins. So this A beta 42 with time starts getting accumulated and starts being phosphorylated. This hyperphosphorylated tau is what is the driving feature of Alzheimer's. Hence, Alzheimer's can be also called as a tauopathy. What is a tauopathy? It is a pathology where abnormal amounts of tau aggregates are being formed. Now, these abnormal hyperphosphorylated taus, they can either accumulate inside the neuron or they can accumulate outside the neuron. When it accumulates inside the neuron, that is what we call neurofibrillary tangles, NFT. That is what we call as neurofibrillary tangles. And when it deposits outside the neuron, that is what we call as a neuritic plaque. That is what we call as a neuritic plaque or an amyloid plaque. Let's say an amyloid plaque. Okay. Now, how are these two things, be the NFT, the neurofibrillary tangles, or the amyloid plaques? How are they harmful? So when these tau proteins get accumulated inside neurons, going to give rise to NFTs, and these NFTs will cause mitochondrial injury. These NFTs will cause mitochondrial injury, and this mitochondrial injury is what will lead to progressive neuronal damage. In case once they start accumulating outside the neurons, that is what leads to the deposition of neuritic plaques or amyloid. And this amyloid, what's going to do is this is a cell, and now it has an accumulation of this cell now has an accumulation of amyloid plaques outside it. What will happen is it will trigger a response from other cells. A response, or let's say a toxic response, is triggered from other cells. A toxic response is triggered from other cells in response to the neuritic plaques which are being deposited outside the neurons. And that, what do I mean by the other cells? I'm predominantly meaning the other cells which are present along the brain or the blood-brain barrier. That is the oligodendrocytes, the microglial cells, and the astrocytes. What are these three forms of cells? They are cells which have a protective function in the brain. So these are suddenly starting to get aware. Like soldiers who suddenly start being aware once there is an enemy who's landed in their territory. Who's the enemy? The enemy is hyperphosphorylated tau. What is causing these soldiers to get awake? It is these neuritic plaques or the amyloid plaques or plaques, whatever you call, which is depositing outside the neuron. What is happening inside the neuron? Inside the neuron, there's a mitochondrial damage due to the neurofibrillary tangles. And what is that damage due to? It's due to a mitochondrial injury that is happening inside the neurons, which is ultimately with time leading to a progressive neuronal damage. So this entire pathophysiology of Alzheimer's is based on APP. It is based on tau. Hence, it is called a tauopathy, and it is based on this entire concept of A beta 42 that we are getting to see here. I hope I'm being clear. So, this is basically what the basic pathophysiology of Alzheimer's is. And do you know something? There's something which is not written in the slide. I can just write it down for you. Have this term called, we heard this term called, I'll write this term right now and I'll open the chat box for a little while. I want you to write to me if you are aware of this term. Have any one of you heard this term called type 3 diabetes, or even for a better way, type 3A diabetes mellitus? We know of type 1 diabetes, we know of type 2 diabetes. Anyone who's aware of type 3 diabetes mellitus? I'll open the chat window for maybe 45 seconds to 1 minute. Can I quickly can I get a response? if there's anyone who knows about type 3 diabetes. Have you encountered this term ever? You know what type 3 diabetes is? We all are aware of type 1, type 2, MODY. What is type 3 diabetes? Anyone? Anyone? Chronic insulin resistance. Very good. Very, very good. What's your good name? What's your good name, my friend? Your name is Arafat, if I'm not wrong. Ayush is writing Alzheimer's disease. Very good. Ayush is writing chronic insulin reassignment. Very good. I'm so glad to have all of you today. I honestly I'm so thrilled to have all of you. Yeah. So exactly. So what is happening is there's this enzyme called the insulin degrading enzyme. Okay. This enzyme called insulin degrading enzyme, which has two works. One is to degrade insulin. The second work is to degrade A beta amyloid 42. So our body is like APP is there. Usually it will be degraded by alpha secretase, but mano galti se, if it's degraded by beta secretase, and whatever A beta 42 is secreted, the insulin degrading enzyme will come and chuck it off. Okay? Consider now a patient of diabetes. Of any patient of type 2 diabetes. What happens? In type 1 diabetes, the insulin is chronically low. There's nothing. In type 2 diabetes, there comes a phase where the body is trying to compensate for the hyperglycemia. What it is doing is the pancreatic beta cells are secreting a lot of insulin. So a lot of insulin is coming. So much of insulin is there in this blood that the insulin degrading enzyme is busy breaking insulin only. It has forgotten to break A beta 42. This A beta 42 is now accumulating, getting hyperphosphorylated, becoming tau, going in neurons, becoming neurofibrillary tangles, going outside neurons, becoming amyloid plaques, making the whole cascade and game for these patients to start off with the cascade of Alzheimer's. So it is a case of chronic insulin resistance wherein there is hyperinsulinemia. So this is what most people usually confuse. They say, in diabetes, how is there hyperinsulinemia? It's because as the glucose is increasing, the body is also trying to increase its insulin levels in order to counteract. Because the increase in insulin, no matter how much, will never be able to counter that increase in glucose because of insulin resistance. This insulin is now freely roaming in blood, which has to be cut off. Cut off by whom? Insulin degrading enzyme. This insulin degrading enzyme normally was supposed to cut both insulin and A beta 42. Now, instead of 20 molecules of insulin, if there's 150 molecules of insulin, insulin degrading enzyme is like, bro, I don't know what to do with this. So let me just put all of my energy in degrading insulin. What remains not degraded is the A beta 42. That accumulates, causes the entire pathophysiology. Am I clear? Am I clear with this segment? Is this clear? Understandable? Can I get a thumbs up from everyone? If this concept is clear, because this is a very emerging, it's a very newly emerging concept. Not really new. It's been there since the last 1 decade. Can I get a quick thumbs up from everyone in the chat group? I think there's a mic which is unmute. Please. Okay. You want me to explain once more? If there's anything that you want, please write to me in the chat. I'll be glad to do it. Okay, so I'm explaining to one more time. I think there's a mic which is unmute. I would absolutely request you
Yeah,
to
I am doing
kindly
it
mute
fine.
the mic.
I'm doing it. Sorry for the inconvenience.
No, it's absolutely okay. Yeah. Okay, so I'll just explain it one more time. Can you just? I am not able to read your name. I'm so sorry. Dr. Shantanu Dasgupta. Okay, hi, Dr. Shantanu. This is nice to get your question. So I'll repeat once more. So normally in your body, you have an insulin degrading enzyme. Everything in my body has a check and a balance. बहुत ज्यादा insulin है, तो insulin degrading enzyme will come, cut it off. Insulin degrading enzyme has two works. On one hand, it will cut off insulin, excess insulin. On the other hand, it will cut off A beta 42. So its role is clear. Excess कुछ भी जमा नहीं होगा. I will cut off insulin. अगर excess आ रहा है, if there's abnormal deposition of insulin, I'll cut it off. If there's abnormal deposition of A beta 42, I'll cut it off. Now consider a case of type 2 diabetes where there's insulin resistance. Yani, there is insulin, but it is not able to counter the excess glucose levels in the blood. What is happening? the body keeps on secreting more amount of insulin in response to a hyperglycemia. जितना ग्लूकोज बढ़ रहा है इंसुलिन उतना बढ़ रहा है. Although it will never be able to cut off that amount of hyperglycemia, but the body's response is, if there's more glucose in blood, I'll release more insulin from the beta cells of the pancreas. इतना इंसुलिन अगर बढ़ गया है that insulin degrading enzyme now thinks that, oh my god, earlier I had to deal with 20 molecules of excess insulin and 20 molecules of A beta 42. Now, insulin degrading enzyme, suppose I am the enzyme, I'm thinking, oh my god, there are 150 molecules of insulin, but the amount of me is still the same. So whom will I target? I will want to cut off all the insulin molecules in excess. Who will be left out? Who will not be degraded? A beta 42 will not be degraded. What will happen to A beta 42 if it's not degraded? It will start accumulating. What will happen if it starts accumulating? It will start being hyperphosphorylated. What will start happening if it's hyperphosphorylated? It's a tauopathy. Once it's a tauopathy, it will go into the neurons, form neurofibrillary tangles, cause mitochondrial damage. If it is outside the neurons, it will now start forming the amyloid plaques. Is that clear now? Should this be good now? Dr. Shantanu, I hope this is good now. Yeah, so now I'll again share you back to my screen. So, taking us back where we were. So, that is exactly how the pathophysiology of Alzheimer's is. Let's quickly see what we have studied. It's a cerebral amyloid angiopathy, A beta oblique A beta 42. Now, naturally, if I have to take this discussion forward from here, what will I say? I'll say this, that in case of Alzheimer's disease, the ratio of A beta 40 by 42 has to be low. Why? Because 42 will be high, 40 will be low. Where will 40 accumulation occur? A beta 40 will be in cerebral amyloid angiopathy. A beta 42 will be in Alzheimer's disease. That's the only thing that I want you to know. Okay. Now, what are these? These are basically extracellular eosinophilic plaques. As I said, plaques are extracellular. When it's intracellular, it will be hyperphosphorylated tau aggregates, which will be nothing but NFTs, neurofibrillary tangles. For people who love patho, this is for you. So the plaques are basically eosinophilic, the NFTs are basically basophilic. That's all. When I talk of genetics, yes, so genetics is one part which we have to talk of, because it has a huge genetic basis as well. There are two genes predominantly. One is PSE and one is presenilin 1, which is located on chromosome number 14. Just wait, located on chromosome number 14. And we have PSEN2, which is presenilin 2, which is located on chromosome number 1. So presenilin 1, presenilin 2, located on chromosomes 14 and 1. Most commonly affected is presenilin 1. Most commonly affected is presenilin 1. And you know why I'm talking about these genetics? So as I said, age is the independent risk factor for Alzheimer's. But whenever there is a genetic mutation, whenever there is a PSEN1 mutation or a PSEN2 mutation, these patients will usually come with early onset dementia. Early onset dementia. And whenever I talk of, so I'll just write here, these will be coming with early onset dementia. And when I write early onset dementia, along with it, what do I mean by early onset? It will be anytime more than 45-year-old patient. There will be seizures and there may be sleep disturbances. So seizures, sleep disturbances, and a patient who is young onset, having a very positive family history, genetics showing PSEN1 mutation, very likely to be a young onset dementia patient of Alzheimer's. If you remember, I was talking of this gene called D, which is located on chromosome number 21. Do you now realize that APP usually is present for everyone? In you, me, everyone, APP is going to be present. अगर Alzheimer's होना है तो APP से ही होगा. But imagine now for a patient with syndrome who is having an extra copy of chromosome number 21. Downs is trisomy 21. So instead of 2 copies of 21, there is 3 copies of trisomy 21. You now understand why these patients having Down syndrome will have early onset Alzheimer's disease, because they are not having 2 but 3 copies of APP gene. Okay? Another thing about genetics which I want to tell you is the role of apolipoproteins. The ApoE4 increases the risk of Alzheimer's, whereas ApoE2 is protective for Alzheimer's. I think this should be clear. Okay. Before I go to the clinical part, I'll again say a few things which are not written, and I would use a blank page for that. The reason I've the reason I have not written everything in the slide is because I don't want this to be, like a session where you feel that I'm, feeding you. It should not be. It should not be a book feeding session. We are all grown up. We need to find out ways where we are learning things. So I'll add a new page. Just give me a moment. Yes. Okay. Now, let's go to the clinical features. When I'm talking of clinical features, uh, so I'll carry forward from where I left. I left here at tau. I'll carry exactly here at tau. So what is happening? The point is, as the tau is starting to accumulate, the initial accumulation of tau is around this entire area, which is called the entorhinal cortex. This is such an important structure. It is one of the hugely important structures involved in your in Alzheimer's disease, basically. So when I'm talking of entorhinal cortex, what is it? It's basically a subcortical structure. And what do I mean by a subcortical structure? It means that it's a part which is embedded in the medial temporal lobe. Embedded in the medial temporal lobe. Anytime I find a medial temporal lobe involvement in the setting of dementia with other features, pointing me towards Alzheimer's, like early memory loss, episodic memory loss, I should always think in the lines of Alzheimer's disease. So initial accumulation is in the entorhinal cortex. From the entorhinal cortex, we will now gradually start moving to hippocampus. In my webinar, in the initial part, I said hippocampus has a huge role in storage in short-term memory. It has a huge role in episodic memory. What is episodic memory? I give you that example when my father was not able to recognize my friend's wife. So, and finally, this will be involving the limbic cortex. Finally, it will be involved. So, initially entorhinal cortex, then the hippocampus, then the limbic cortex. Now, from the limbic cortex, once the limbic cortex is being involved, you will have behavioral changes. You will have behavioral changes in the form of apathy, agitation, restlessness, at times rage. All of this will be there. Okay. And beyond the entorhinal cortex, whenever it has progressed, the final areas that will be affected is the sensory areas and the motor areas, which is why until late stage of Alzheimer's, most of these patients have a very well preserved sensory and motor functions. They'll be able to, if you show them the spoon and tell pick up the spoon, they'll be able to pick up the spoon. If you keep a hot bag on their back, they'll be able to tell you that okay, it's a hot substance which is being kept. So as I said, these tauopathies will start moving from the entorhinal cortex to the hippocampus. And can you see early involvement of hippocampus? Sorry, the early involvement of hippocampus is what is leading me to the symptoms of episodic memory loss, short-term memory loss. This is exactly what explains Alzheimer's, that there's an early memory impairment. There's an early memory impairment. As I move on to the other causes of dementia, you will actually start finding that memory is not the first thing that is involved in other things. Yes, memory impairment is there, but not the first thing. So we'll be discussing that along with when we move to the other sections. So yeah, it is these NFTs which are there in the hippocampus and the medial temporal lobe, which is responsible for the first cognitive symptom in most patients, that is a memory impairment, episodic memory impairment. Okay, now what happens to long-term memory in these patients? Long memory, as I said, long-term memory is usually preserved. So I told my father, giving an example, if my father had Alzheimer's, he'll be able to remember Rahul. Rahul is remembered, but Rahul's wife is not remembered. Rahul's wife is not remembered. Okay, so that is exactly what is the memory impairment that we find. And the sad part, why I said that seeing these patients is really sad, is by the time these clinical features start to manifest, accumulation has happened in almost 60 to 70% of the brain, which means there's no in the preclinical phase, basically the the patient is actually silent. There's no manifestations of the disease in the preclinical phase. And by the time the clinical phase has happened, the A beta plaques have already widely distributed, mainly in the frontal and the parietal lobes. And this is why, by the time we are seeing the patient, a lot of this disease has actually progressed. A lot of this disease, to be honest, has really progressed, which is why, and today, whatever treatment options we have for Alzheimer's, none of them right now target this pathology except the monoclonal antibodies, which is like aducanumab or lecanemab. But then they're all found in the West. They are not found in India. The treatment cost is over the roof. I mean, as I said, it's like 40, 50 lakhs per year. That's the treatment cost. The other medicines that we find here in India are predominantly symptomatic managers. They are drugs which do not target the real pathology. I'll talk about them when we talk of the treatment sections. So as I said, the sensory and motor symptoms are found late. Only in the later segments, in a very advanced stage of Alzheimer's, will you find tremors happening. You will find extrapyramidal symptoms happening. You will find myoclonus happening. You'll have gait abnormalities that will come in. So these are very late features. So the mood changes, the early memory impairment, irritability, and one thing that I forgot to tell you is patients have this famous thing which is called anosognosia. What is anosognosia? Anosognosia is not being aware of the deficits that they have. I mean, I can still recall one of my patients whom I asked that, your husband and your daughter are evaluating you. They're taking you to the doctor. Do you know why? What is your problem? And I clearly remember her telling me, I don't have any problem. So these patients are blissfully unaware of their own deficits, unaware of their own deficits. They are not ready to, they don't realize that they are losing their memory. They don't realize that they are losing their episodic memory. They don't realize that their behavioral changes are occurring. It's only something which is visible to the caregivers, which makes this such a difficult area to target. So as I said, most of these patients will always say this: I don't know why I am in the hospital. I don't know why I am in the hospital. So this is the usual response. Uh, I think there's a mic which has been unmuted. Can you just be kind enough to mute it?
Sure, I'm doing it. I'm doing
Yeah.
it. Just give me a moment. Yeah, I did it. Thank you.
Yeah. So as I said, that in these patients, you will have a state where you will not be able to really they don't know of their own deficits. And the worst part is, as I keep saying, that for the caregivers, it is so important that somebody hears them out. Somebody knows that it is so difficult in dealing with these things, because the patient does not know what is happening. And we gradually start losing the patient. It's like when you have a heart attack, or say you are having diabetes or you're having hypertension. It's all a treatable cause. The patient knows that, okay, I had a heart attack, I don't need to do this, I don't need to eat red meat every day, I don't need to smoke, I don't need to drink. But then in these cases, you don't lose the organs, you lose the person, you lose the entire personality of this person. So that is something which is really sad. And it just keeps progressing with time. So uh, mm, what about language and speech? Initially, there's a word finding difficulty. Initially, there's a word finding difficulty that you find, which is so called anomia. So anomia is nothing but word finding difficulty. What is word finding difficulty? You show this patient a picture of a camel and say, "What is this?" She will probably say that, "Okay, I know this is an animal that lives in the desert," but then will not be able to recall the word camel. So word finding difficulty is what we call as anomia. And as I said, there will be associated behavioral changes. There will be associated psychiatric manifestations as well. Psychiatric manifestations in the form of depression with time. There may be apathy, as I said. There may be dysthymia. There may be a very, very, very labile mood in these patients. Sometimes they'll get very irritated. Sometimes they'll start crying. There will be no identifiable cause of crying. You'll just find tears rolling down the eyes of these patients. So that is something which we find in association with these patients as well. And with time, from having anomia, gradually have a point where their comprehension reduces. All I'm saying is the later stages of the disease. Reading ability reduces, writing ability reduces. Whatever you say, they are no more able to write down in words, and that is exactly what we call as dysgraphia. Dysgraphia. So. Uh, calculation abilities, all of this starts involving, because like I'll show you a diagram in a while. I'll draw a hand-drawn diagram for you so that you understand how the stage of this progresses. So that is all I wanted to tell you about the clinical picture of the disease. So let's quickly see what is here. There are four A's. There are antegrade amnesia, which is forming new memories early. There's aphasia. There's agnosia. There's apraxia. Apraxia is calculation defects, which I'll tell you later how. Psychiatric features are there. Wandering is a very significant thing that we find in cases of Alzheimer's disease, and it is said that it is it's the involvement of the parietal and the involvement of the parietal and the posterior cortical areas, which leads to wandering. What is wandering? Basically, so this patient will go out of the home. She will forget why she went out of the home, and now she will not be able to navigate her way back home. Why? Because the parietal lobe of this patient has started being involved. From the temporal lobe, it starts moving to the parietal lobe. From the parietal, it gradually comes and starts involving the frontal lobe. So whenever the parietal lobe is involved, this patient now has visuospatial dysfunction. Means the patient is not able to navigate outside. She doesn't know why she went outside. If you ask her, she's not able to know, because she did have a thought while she came outside, but by the time she came out, she forgot why she had come outside, and now she's not able to navigate her way back home. As I said, motor functions and sensory functions are normal until late stages of the disease. When I talk of workup, the gold standard is always a brain biopsy. I mean, who's going to do a brain biopsy in a live patient? Brain biopsy will show me the accumulation of neurofibrillary tangles. It will show me the accumulation of taus, all of that. But what do we have in practice? It's an FDG PET MRI, which shows a hypometabolism in the medial temporal lobe. Hypometabolism in medial temporal lobe. As I said, medial temporal lobe structures are something which are going to be, involved. That will take care of the memory. That will take care of the executive functions gradually. These will start getting lost. Some biomarkers are coming up with time, where we are having some PET MR machines which are using A beta amyloid tracers, which means that these PET MR machines are now able to detect the amount of amyloid depositions. And believe me, it is something where they will be able to detect the amyloid accumulation much before the disease has actually started being diagnosed, because I already told you there's a huge preclinical phase in this disease, which remains unnoticed. So for a patient who's having a very high family history of Alzheimer's, it is very important that the caregivers right now who are normal, who are asymptomatic, it's good if we can screen them, if we can find amyloid depositions, if we can do something in order to halt the progression of the disease. In you will have certain markers like A beta by tau ratio. There'll be phosphorylated tau levels will be high, and all of this is going to be, these are all new biomarkers which have come up. FDG PET MR is something which we very oftenly do. CSF studies are not really done in every center in India. FDG PET MR is done in good neuro centers in India. PET tracers, not all centers have this. Very few in India have this. So it's mainly in the West. I'll talk of treatment a little later, but I'll once want to show you a few things. So if you can see this, this is the clinical. So this patient got symptomatic here. Okay, there's a patient got symptomatic here. See, 20 years before this patient actually got diagnosed, just see, tau kept increasing, amyloid plaques kept increasing, clearance of amyloid was impaired, neurofibrillary tangles kept increasing, hippocampus involved in memory started decreasing in volume, memory started decreasing, metabolism of temporal lobe started decreasing, associated with behavioral changes, depression. And all of this due to oxidative stress, inflammation, microglial activation due to plaques, and neuronal loss due to mitochondrial injury due to neurofibrillary tangles. That is all about the graph showing how many changes have already occurred before this patient got diagnosed. So by the time patient is diagnosed, it's already spread a lot. This is figure A showing a brain change at biopsy. This is a biopsy change. You can see the loss of the medial temporal lobe structures, how much of atrophy has happened. This figure C that you see right here, the black arrowheads that you see, these I mean, these are predominantly the the amyloid plaques that are accumulating. As I said, amyloid plaques are extracellular, and these ones you see here that I'm highlighting right now, the ones with black arrows, these are basically your the neurofibrillary tangles containing the hyperphosphorylated tau proteins. So that is all about Alzheimer's. Just a few things which I wanted to say. Is impaired. These are simple questionnaires that you can screen. Orientation is impaired. Judgment and problem solving is impaired. community social affairs, ability to work or volunteer outside of home, purchasing a short list of items from the store. Social engagement is impaired, participation in activities, marriage functions. These patients should not be allowed to drive because they have gradually lost their procedural memory, they have gradually lost their sequential memory, and they find difficulty in their home. Gradually with time, they find difficulty in navigating bedroom, bathroom, kitchen in their home, which is why it's very important for the caregivers to keep signals and give them cues that go straight, take a right, that's where the washroom is. Go straight, take a left, that's where your kitchen is. And of course, personal care is which starts getting affected. I found so many patients where these patients have stopped complaining whether their clothes are being soiled, whether their clothes are wet. They do not flush after they come out from the toilet. So these are all very common features that we get in this disease. And as I said, language, motor planning, execution, visuospatial perception, that is where my home is, how far my home is from the market. If I go to the market, will I be able to come back to my home? All of this starts getting involved in the long run. So that is predominantly Alzheimer's in a nutshell. I've not yet talked of the treatment. I'll just draw a random thing so that I can tell you how the progress of Alzheimer's occurs, because I think this diagram it's a very hand-drawn diagram. I'll try to draw this out for you. Uh, so if this is the brain, just saying in a nutshell, here is my hippocampus, here is my angular gyrus, here are my association areas, here are my superior parietal lobule structures, and here's my prefrontal cortex. Superior parietal lobule, is major for what we call as praxicons. What is praxicons? I told you, it's the formula for movement. Like, okay, if I need to propose a girl, I need to get up, take a rose, go to the market, get a rose, go to the girl, bend down, be modest, be humble, express my love, and then propose. That this formula of this entire movement is exactly it's what praxicon is. So timers just involves like this. This is the method. So prefrontal cortex involved last, angular gyrus involved early, hippocampus involved early, thereby causing memory dysfunction. Angular gyrus involved early, hence causing acalculia, that is not able to calculate things. Association areas involved early, leading to visuospatial dysfunctions, not able to navigate between homes, rooms in the home, or homes in the colony. Superior parietal lobule not able to execute. They'll stand at a place. They'll not know how to cook a dish that they've cooked for the last 20, 30 years. They'll probably stand in the toilet or the washroom with a mug. They don't know how to take a bath, or even though the water is filled to the bucket, they don't know how to proceed with it. Finally, the prefrontal cortex involving the social, how, what is the difference between a public and a private space, how to behave in home, how to behave outside. All of this gets late involved. So these are the organs which gets involved, the hippocampus, angular gyrus, and the association areas. So that's just like a very brief description of how things progress. This you can see, these are all MRs which have been taken from cases. Okay, these are all live cases MRs. That is why I've tried to put in this is a sequence. Just sorry, this is a flare sequence, and you can see how much of atrophy is there. This is the normal brain. This one is the normal brain. Can you see how much of atrophy has happened? Sorry, just a minute. I said wrongly. This is an Alzheimer's brain. This is the amount of atrophy that has happened. There's global atrophy. There's atrophy of the medial temporal lobe structures, atrophy of the hippocampus. There's a decrease in hippocampal volume. Hippocampal volume, you can see, is decreasing with time. It's decreasing. So these are all things which have been taken from live cases. And somebody was telling if exercise and all of that can help. Yes, as I said, activity can predispose to Alzheimer's. Hearing loss can predispose to Alzheimer's. Obesity can predispose. Social isolation can predispose. Air pollution can predispose. But all of this you can correct as long as it is not diagnosed. Once the changes have started to happen, you cannot stop these changes. These findings again. So this normal, you can see, compare it with this. Look at the amount of atrophy. Look at the amount of atrophy. Look at these structures and this structure. Look at how much of atrophy has happened in the medial temporal lobe and the hippocampus. Look at the amount of volume that has been lost in the brain. And this is even severe. Like this. So this is mild. This is moderate. This is moderate to severe. That is exactly how things are. And this one again, you can compare this, as I was talking of hypometabolism. So yeah, this is normal. This is normal. Look at the atrophies here. Look at the dilated ventricles. So much of atrophy has happened. So much of cortical atrophy has happened that the ventricles have started getting dilated. This is a normal brain showing. This is a PET MR. This is a PET MR. And if you can clearly see, this is the normal metabolism of the occipital and the temporal lobe. This is normal temporal lobe metabolism in red. Can you see there's no red marking here, which shows a decreased uptake in the medial temporal lobe? Bilateral medial temporal lobes being affected. These are amyloid depositions. This is a normal brain. Look at the amount of amyloid that has been deposited. The green ones are look at the amount of amyloid that has been deposited throughout the brain. So these are all live images that I've tried taking from journals. I'll quickly take you through this case again for you to understand. This old retired nurse and with hypertension, hypothyroidism, 1 year history of memory is concerned, elder daughter, gradual onset progression of repetition of questions and misplacing of items, forgets recipes while cooking. The neurological examination was around 20/30 on MMSE. You don't need to know the scale, but thyroid function tests are normal, vitamin B12 normal. Can you see how they've evaluated any reversible cause first? They evaluated thyroid, they evaluated serum vitamin B12. FLAIR MRI shows diffuse global atrophy, periventricular and subcortical T2 hyperintensities. You will have left more than right hippocampal atrophy, mild cognitive impairment secondary to Alzheimer's. Cognitive effects progressed, leading to increased reliance on our daughter to manage medications, finances, and meal preparations. And you can see the performance is also decreasing. Initially, it was 28, now it's 23. Amyloid shows increased cortical uptake, moderate to severe burden of amyloid plaques. This is a typical case of Alzheimer's disease. So, what do we have for treatment? Basically, nothing. To be honest, right now in India, nothing. All we do is trying to improve the cognition. You can try improving the cognition basically by increasing the levels of acetylcholine in the brain. As I said, you can increase the levels of acetylcholine because this thing called nucleus basalis of Maynard is what is involved. And how do you increase acetylcholine? By giving acetylcholinesterase inhibitors. You have initially this drug came out, Tacrin, but Tacrin was found to be hepatotoxic, removed from the market. Then came this drug, DRG section of drugs. D is donepezil, R is rivastigmine, and G is galantamine. You have these names here, donepezil, rivastigmine, and galantamine. And among this, rivastigmine is the only drug which can be used as a transdermal patch, The rest are given orally. You also have an NMDA antagonist, which is memantine. In today's treatment protocols, you usually, for mild diseases, you just give donepezil. And in moderate diseases, you add donep with memantine. That's the protocol. Dosages will vary. But as I said, we are just increasing the acetylcholine levels in the brain. We are not targeting the hyperphosphorylated tau. We are not targeting the beta secretase pathway. We are not targeting NFTs. We are not targeting amyloid plaques. Recently, 2021 onwards, these two monoclonal antibodies have started where they have started to, show some response on aducanumab and lecanemab, but then these are found in the West. They have their own side effects as well. Trust me, this side effect is called ARIA. That's amyloid-related imaging abnormalities, which have been found once treatment with these drugs were initiated. Donepezil and memantine are relatively safe, but aducanumab and lecanemab are drugs, are monoclonal antibodies, which although these drugs have targeted the A beta pathway, but they have their own set of side effects as well. And I'm going to show you the side effects in a while. This is ARIA for you. So patients post use of aducanumab or lecanemab, they have landed up with cerebral edema. You can find this gross cerebral edema. This cerebral edema for you. There's also slight effusion that you find in these regions. You can have, again, this is circle. There's a circle effusion. You can also find microhemorrhages. So again, they all come with their own negative effects. We are yet to find out a treatment where we are targeting the real pathology, that is the hyperphosphorylated tau, and we are also not causing much of side effects. There are some trials which are on, by the way. I'm writing the name of this trial. You can please Google this up. It's called the Umber trial. It is being performed right now in NIMHANS, Bangalore. And it's an Indian trial where we are trying to do plasmapheresis. We're trying to do plasmapheresis with albumin replacement. This is a very, very recent trial. I've been a part of, uh, you know, a part of this team who are doing this trial. I have some baseline knowledge of this trial because I am pretty aware of what is going on here. Uh, they are doing albumin replacement with plasmapheresis, wherein we are trying to clear off. It's mainly like dialysis only. We are trying to clear off the A beta plaques. But then, how effective it is in the long run, we don't know. Thankfully, we don't have as big side effects with aducanumab and lecanemab. They have a lot of side effects. At least amber does not have side effects for that matter. So we are just trying to clear the load of A beta amyloid plaques and NFTs as much as we can through this trial. Amber trial, you can Google it up, AMBAR. So that is all about Alzheimer's for me. I will open the chat window for any doubts and anything that you want to tell me regarding Alzheimer's. I'm open to viewing your questions. Please forward the PPT. Yes, Gagana, is there a procedure by which we can forward the PPT? Can we do
Yes,
that?
definitely. We will be sharing the PPT.
Yeah, please share the PPT. Yeah, I think the PPT will definitely help you. But as I said, I would there's a lot that I'm saying in this class which are not written and deliberately not written because I want that thing to be absorbed. Is there any questions that you have on Alzheimer's right now? In anything that you have? The other dementias are not something which will take this much of time, but Alzheimer's is something which is huge. It's absolutely huge. I tried to give as many number of case examples that I could. I would entertain questions, anything that you have, anyone in your family, if you know any relative who's being diagnosed with this. My heart goes out to all of you. Uh, I I only tell you this: if it's a genetic cause, please get yourselves evaluated. Please keep in touch with what is happening because you do not know what is going to come up in the next 10 years. I really hope something does, or we as doctors we can take this initiative up. We can try working and see what we can do because, as I said, the treatment modalities in India are not up to the mark, well, which is cost effective as well as targeting the real pathology. So, any questions? I'll take 2 minutes to take up questions.
Please drop your questions in the chat box. We'll do the best to answer them. Additionally, I'll be dropping a chat box in a while. Kindly please fill and submit to get your participation certificate. And your feedback is valuable to us. Kindly drop your feedback in the same link. Thanks. Thank you so much.
Any questions? Post which I'll move to Lewy body dementia and frontotemporal dementias, which are another very common segments that we encounter. Moghal Lalu, hi, thank you so much, thank you. Trust me, each one of these appreciations that I'm getting means a lot to me, and I will I'll try making these sessions as interactive as I can. That's the form of education that I believe in. Keeping it very transparent, keeping it very interactive. I think we have a question. Dr. Shantanu, thank you so much. I think there's a mail ID which has been sent. I think that's all for the feedback purposes. I guess I'll move on to my next segment, which is frontotemporal dementia, and I presume that there's one more question. Thank you so much. Okay, thank you, Dr. Abbas. It means a lot. Lots of love. Okay, I'll get back to sharing my screen again, and presuming there's not much of questions that we have, I'll move to sharing my screen. Okay, so okay, now the rests are comparatively better. So let's talk of Lewy body dementia. So this is something which again it's very confusing. Why in the first set a Lewy body dementia sounds as LBD, but then you have another variant and trait which is DLB. So don't get confused. Lewy body dementia has two entities in it. One is a Parkinson disease dementia. The other is a dementia with Lewy bodies. Why are they grouped together? Grouped together just for this one reason that they have a common accumulation of a substance which is called alpha. Just a minute. Let me align my screen properly so that's easier for you to visit. Yeah. So because of this thing called alpha-synuclein, this is an abnormal protein aggregate, unlike just like what we found in cases of Alzheimer's, right? We found hyperphosphorylated tau. Here you have abnormal aggregation of alpha-synuclein protein, which is very common to the pathogenesis of both these disorders. That is exactly what leads us to keeping both of these under the same spectrum of Lewy body dementia. Now, the point is how what are there any other similarities that we have which can make us think in these lines? Why have we kept these two under this name of Lewy body dementia? Is it just alpha synuclein? No, it is because EPS symptoms can be found in both. So all the extrapyramidal symptoms that you find in a Parkinson patient, what do you find? You have tremor, you have rigidity, you have akinesia. Okay, all of these are something which is equally found in patients of dementia with Lewy bodies. Then that poses a bigger challenge to us. The challenge that it poses is how do we understand that is it a Parkinson disease dementia or is it a dementia with Lewy bodies? Before I begin this segment, I said Alzheimer's is the most common cause of dementia. Dementia with Lewy bodies is the second most common cause. I mean, it's a part of, as I said, it's a part of something which is called alpha synucleinopathies, where where there's an intraneuronal accumulation of alpha synuclein. As I said, it is intraneuronal. In Alzheimer's, what was intraneuronal? It was neurofibrinogen tangles. This is intraneuronal and intracytoplasmic. So it's intraneuronal, intracytoplasmic accumulations of alpha-synuclein. And as I said, these are alpha-synucleinopathy. Alzheimer's was a tauopathy, correct? And when I talk of alpha-synucleinopathies, all of these diseases which have abnormal accumulation of alpha-synuclein protein, they come with a few things, which I will be first talking, that how am I differentiating it from Alzheimer's, and what are the things which makes me think more in lines of LBD. So the first, what differentiates these from Alzheimer's is memory impairment is less marked unless in later stages. This is complete contrast to what we studied in Alzheimer's. If you can clearly look to this, where I had marked this, memory was the first thing that was involved in Alzheimer's. In these patients, memory impairment is considerably late or less marked unless in later stages. Next, spatial executive dysfunction occurs early and is more impaired. Here, as you can see in Alzheimer's, this was a late involvement. First memory, then angular gyrus, which was leading to calculation problems, then visuospatial defects due to association areas involvement. So visuospatial defects were a later involvement, whereas in cases of LBD, that's Lewy body dementia, you have them being involved earlier. With hallucinations and delusions, things which we never encountered in case of Alzheimer's disease. We did talk of psychiatric complications, but they were all related to irritability. They were all mood changes, basically depression, irritability, apathy, anosognosia. All of that was there, but there was no case where I discovered where I talked of a visual hallucination or a delusion for that. So any of these two being present points a little more towards LBD. Sleep behavioral disorders. This I cannot tell you how important this one line is. So I'll show you in a while. So this REM sleep behavioral disorder, which is why I have marked it in a bold. REM sleep behavioral disorders and cognitive fluctuation. These two words, one is a fluctuating pattern of cognitive deterioration, which means in the morning these patients are good. By the evening, these patients suddenly start deteriorating. Very much reflects something which is called delirium. A very clear differential diagnosis of this is delirium. Because in delirium, we have this famous thing called sundowning. What is sundowning? Most patients in ICU, okay, old age patients, in the morning they are fine. From the evening, they are having altered mental status, confusion, irritability, okay, jitteriness. All of this is delirium. So because it occurs post sunset, we call it sundowning. Cognitive fluctuations, which very much resemble like delirium, are very, very, very characteristic of Lewy body dementia. And REM sleep behavioral disorders. So this is the polysomnography. What is REM? REM is rapid eye movement. You can see electrocardiogram is showing movement. Just a minute. Electrooculogram is showing movement. which means it is REM. In your REM phase, normally the muscles need to be atonic, which means when you go to sleep and you are in the REM cycle of your sleep, your muscles should not move. Your legs should not move while you are sleeping. You should not be kicking around people. But these patients, you can clearly on electromyography, there is a clear spike. Even so, loss of REM atonia. Normally, there is atonia during REM. Whenever there's a loss of REM atonia, we are going to get REM behavioral disorders. These patients might talk in their dreams, they might kick you in their dreams, they might punch you in their dreams, and you don't know what is going to happen. So this typical hallucination, the delusions, the REM behavioral disorders, cognitive fluctuations should make you differentiate this patient from Alzheimer's. What are the factors which increase the suspicion of LBD? Although they increase the suspicion, they are not diagnostic minded. Please, they are not diagnostic. One is depression, anxiety, apathy, which were also associated with Alzheimer's. So I won't really go into much of this. Hallucinations in other modalities. As I said, hallucination in itself rules out Alzheimer's in a lot of ways, because uh, in Alzheimer's, it's a medial temporal lobe which is involved, and medial temporal lobe has got nothing to do with hallucinations. But in Lewy body dementia, be it Parkinson disease associated or dementia with Lewy bodies, there is hallucination in every modality. Initially visual, but then go to auditory, it can be tactile, it can be gustatory, that is taste sensations. This patient can just suddenly say that, he's tasting biryani, even though there's no biryani around. These patients are associated with frequent falls. Why? Because of the involvement of basal ganglia structures. Basal ganglia involvement leads to frequent falls because basal ganglia plans and coordinates our motor movements along with cerebellum. Basal ganglia are not there, planning of movement not initiated, frequent falls, syncope, hyperosmia, constipation, orthostatic hypotension. So all of these things. So basically, we call these as autonomic dysfunction. So autonomic dysfunction is what we broadly call these terms as. Just give me a moment. Yeah, so autonomic dysfunction is what we broadly call this term as, wherein we will be having postural hypotension, where we will be having erectile dysfunction, where we will be having, urinary abnormalities, and you might find an overactive bladder in these patients. So all of this coming together with frequent falls, syncope, hyperosmia, hyposmia, constipation is such a common symptom. It's something which we don't consider very seriously in the setting of evaluation of these dementia patients. But trust me, a common history would lead to, a proper detailed history would lead to a lot of these things coming up, where we find that majority of patients giving one common complaint of constipation. The last, which again written in bold, sensitivity to classic neuroleptics. What do I mean by a classic neuroleptic? It is haloperidol. For example, I have given this patient haloperidol. What is haloperidol? It is a typical antipsychotic. So suppose a patient has come to me with features of acute psychosis. I give this patient a typical, I don't know what this patient is. This patient has suddenly popped up in my emergency with, showing hyperactive, agitated, psychotic features. I will initially think in terms of alcohol and intoxication, in terms of other intoxications. I will give Peridol to this patient because it's a typical antipsychotic. It will deplete dopamine, because in these patients already, suppose it's a Parkinson disease patient, already dopamine levels are low. I further deplete dopamine, there is sensitivity, which means EPS symptoms worsen. EPS symptoms worsen. The tremor, the rigidity, the akinesia, all of this starts worsening. So all of this should make you think higher in form of LBD, although these are not diagnostic. Quickly summarizing the differences, as I said, call marked impairment in Alzheimer's disease, recognition, marked impairment, as you see, none or minimal. Prompts or cues. This is so important. Any Alzheimer's patient, if they are not able to say, suppose I've shown the picture of a camel, and they're not able to say what that animal is, no matter how much I try to tell them that it's found in a desert, very rarely will it happen that they'll be able to recall it. But these patients of Lewy body will be able to recall in most of the cases when they are prompted. Intrusions are marked in both cases. Semantic memory, moderately affected. Insight, as I said, markedly affected. Why? Insight is very much a part of prefrontal cortex. Prefrontal cortex involved in later stages of Alzheimer's disease. Okay, attention, here marked involvement is there. Executive function, marked involvement. Visuospatial skills, marked involvement. Why? This is due to involvement of So here also there is a temporal lobe involvement, hippocampal involvement. Executive dysfunction is again marked because of the basal ganglia structures being involved. They don't know how to initiate a movement. They don't know how to plan and program those movements. And visuospatial skills again involved because of the temporo-occipital association areas. You'll find when I show you the MRIs that the temporo-occipital association areas are involved. So yes, this is showing you one Alzheimer's. This is dementia with Lewy bodies. You can clearly see global cortical atrophy with dilatation of ventricles, which are disproportionate to the atrophy of the cortical atrophy. There's the involvement of the hippocampus, medial temporal lobe structures in Alzheimer's disease. Whereas in case of Lewy body dementia, you do find cortical atrophy, you do find ventricular dilatation, but the hippocampal atrophy, can you see this? Can you see this and you compare this? I'm just trying to mark this out for you. So it makes things a little better. You see this. Can you see how much of atrophy has happened in the hippocampal structures? Compare it with this. Not much atrophy has happened because the hippocampus is almost very, very well preserved in Lewy body dementia or dementia with Lewy bodies or Parkinson dementia. We are usually coming to a place where episodic memory is something, or short-term memory, something which is not really involved in these patients. This is an FDG PET MR. FDG PET MR patient with dementia with Lewy bodies. You can find areas of hypometabolism in the bilateral occipital lobes. This is occipital lobe. If you remember, I had shown you a normal. This is how a normal thing looks like. You can see so much of red in the occipital lobes. See, there's nothing in the occipital lobes. Nothing, almost nothing in the occipital lobes. Little bit of red here, but almost nothing. Which is why I said the temporo-occipital lobes are involved, which leads to the visuospatial dysfunctions. What you will clearly find is, even though the occipital lobes are being involved, but the posterior cingulate gyrus, the area of the posterior cingulate gyrus showing the arrow in the red mark, the white arrow showing the red marks, that is, however, preserved. So bilateral occipital lobes are involved. Hypometabolism is there with preservation of uptake in the posterior cingulate gyrus. This is what we typically called as the cingulate island sign. Cingulate island sign. So again, less amount of hippocampal atrophy, more amount of occipital atrophy, hypometabolism, and preservation of the cingulate iris. Again, now when I come to this, as I said, if there are so many features which are similar to both of them, how will I differentiate between PD dementia and dementia with Lewy bodies? Well, as of now, we have one criteria that we use. That is, we say when if so, first a patient shows features of Parkinsonism, and after 4 to 5 years, this patient shows features of dementia. We call it PD dementia. If the features of dementia precede or are concurrent to Parkinson, concurrent with Parkinson symptoms, then we usually classify it as dementia with Lewy body. As I said, the visual hallucinations and the fluctuating alertness, the fluctuating sense of consciousness, the fluctuating consciousness that I talked of is more here. Fluctuating consciousness is more in these patients than the patients of Parkinson. And tremors, on the other hand, are something, as I said, tremor, rigidity, akinesia are something which is more in cases of Parkinson's dementia. Gait abnormalities are common in case of dementia with Lewy bodies. Gait abnormalities are not really common in these patients. And, as I said, effect of antipsychotics. So, sensitivity to neuroleptics is something which is marked again in dementia with Lewy bodies. It will worsen the symptom because of D2 receptor inhibition. And if I give L-DOPA to these patients, nothing will happen because the problem is alpha-synuclein pathways. But here, because dopamine was being degenerated, if I give L-DOPA, this patient will show improvement. So L-DOPA shows improvement. Summing it up, PD dementia, it is Parkinson's first, features of Parkinson's like tremor, rigidity, akinesia, and then 4 to 5 years later, you're having a dementia or a neurocognitive decline. In cases of dementia with Lewy bodies, you are having a concurrent or the dementia is often preceding the Parkinson features. Excessive sensitivity to neuroleptic is DLB. Fluctuating consciousness, gait abnormalities is DLB. Good response to L-DOPA is Parkinson's. That is the mota, the classification that we can do. When it comes to treatment, again, Parkinson, you will just keep on giving L-DOPA. But in case of dementia with Lewy bodies, you can never try the treatment of Parkinsonism on them, because I'll tell you what happens is, so if I talk of L-DOPA, as a disease, giving L-DOPA, L-DOPA will improve the motor symptoms of Parkinson's, right? But one thing that it definitely causes is it increases the amount of dopamine in the brain, which causes psychosis features in these patients. So as I was saying, L-DOPA will cause a good response in Parkinson's, but in the long run, they will increase dopamine in the brain. This dopamine will cause psychosis. So this is one challenge that we face. The other challenge, so that is why we say that, if at all a patient of dementia with Lewy body comes, unless the motor symptoms are so predominant that they are interfering with life, unless the motor symptoms are so significant that they are interfering with the activities of daily living, do not give L-DOPA, which is why I said L-DOPA has very negligible response in patients of dementia with Lewy body. Whenever I come to treating the REM behavioral disorders, these disorders, the REM behavioral disorders, that is exactly where I will try to put patient on melatonin, which is usually 3 mg to 9 mg we give. It's the first line drug. It's given once daily at night. Clonazepam can be given at a very low dose, as low a dose possible. It's a long acting benzodiazepine, but then it has a huge impact on falls. It has a huge impact on syncope. These are mainly elderly patients, and you cannot risk, giving them clonazepam. It's better that you avoid it. Melatonin, that should correct the REM behavioral disorders. Also, in these patients, once you find the REM sleep behavioral disorder, also try to rule out the other causes of REM behavioral disorder. ऐसा नहीं कि, dementia with Lewy body is the only cause of REM behavioral disorders. You have obstructive sleep apnea, which can cause REM behavioral disorders. So check out that. You have restless leg syndrome. If this is the case, then you have a different treatment. You have pramipexole, and you have periodic limb movements. So please Google this up. After this session, what is the difference between restless leg syndrome and periodic limb movements? They sound similar, but they are not. I can only give you a hint. In one of these syndromes, you come with a complaint that, doctor, I feel I am kicking in my sleep. In the other, your wife comes with the complaint that, doctor, my husband is kicking me in sleep. That's the only clue that I'll give you. It's for you to find out what's the difference between restless leg syndrome and periodic limb movements. The treatments are different. And as I said, for the behavioral symptoms, because these patients will come with a lot of agitation, they'll come with a lot of psychotic features, depression, anxiety, hallucinations will be there. So the biggest is, if I give them a tricyclic antidepressant, they have a lot of anticholinergic properties. Because of these anticholinergic properties, there will be a lot of autonomic dysfunction that can happen in these patients. I cannot give these patients benzodiazepines because benzodiazepines will cause refractory agitation. As I said, it's always better to avoid benzodiazepines in these patients because it will cause refractory agitation. It will cause sedation. Excessive sedation might lead to them falling down, might lead to them having repeated syncopal attacks. Some few antipsychotics have been used, but then again, they are atypical antipsychotics. They are not typical ones because these patients of dementia with Lewy bodies have extreme sensitivity to the normal typical antipsychotics. The atypical antipsychotics like quetiapine or say clozapine, they have been used, but then again they come with their own distresses. Clozapine has a very common and notorious effect of producing agranulocytosis, so you need to keep monitoring the WBC counts of these patients always over a period of few months to few 2 to 6 monthly. You have to keep on monitoring the WBC levels of this patient, which makes it very difficult because these patients are not really in a state where they'll be able to cooperate and aligned to the treatment protocol that you'll be giving them. So that is something which makes this very challenging. Just coming to a case before I sum up DLB. 75-year-old man, 2-year history of progressive cognitive decline, behavioral issues, difficulty with memory, with word recall, improved with recognition and cueing. This should be a very important clue for you because this is not something which you find in Alzheimer's. Executive function tasks, visual construction, fluctuating attention. So all of this was impaired, right? Mild mood changes, depression, apathy was present. Frequent visual misperceptions. Now comes the point where we are thinking more in terms of dementia with Lewy bodies, because there's visual hallucination. He's mistaking furniture for people, but it was unclear from the medical history whether they were overt visual hallucinations. I mean, often the informers or the caregivers that come, they're not capable enough to diagnose what a hallucination is. On physical hallucination, you have the extrapyramidal symptoms, mild bradykinesia. No other Parkinson features were found. No resting tremor, no rigidity were detected. Given all of this, the probable diagnosis of dementia with Lewy bodies was suspected. Why? Why was it not Alzheimer's? Because the memory was improving with cues. There was, the visual hallucinations. All of this was making them feel that, okay, maybe this is a case of dementia with Lewy bodies. How do we confirm? We took dopamine transporters, single positron emitted, tomography. That's a dopamine SPECT, and that showed us decreased uptake of the tracer with evidence of dopaminergic degeneration involving the putamen. The presence of dementia, one core feature, that is cognitive fluctuations, and no clear picture of another core feature, but the presence of an indicative biomarker, that's the dopamine SPECT, supported a diagnosis of DLB. You can see this very clearly. This is the healthy patient. Look at the amount of dopamine uptake. This is the abnormal patient with DLB. Look at the amount of dopamine uptake. There's a reduced dopamine uptake in the putamen. Fluctuating cognition. Fluctuating cognition is something which is again going to push you more towards dementia with Lewy bodies. You also did not find frank features of tremors, rigidity, or any other EPS symptoms, which made us think not in terms of Parkinson's disease. This one again, a woman, 3-year history of progressive memory decline, originally diagnosed as Alzheimer's disease. Now, this is a very interesting case where she was initially diagnosed as Alzheimer's, who started her on donepezil. During brief hospitalization for a treatment of UTI, she experienced an episode of delirium and hallucinations, which was treated with low-dose haloperidol. This is very common. An elderly woman coming to us, UTI, in the ICU, she faces ICU psychosis. We once decide to put her on haloperidol. Suddenly, what we find, although her neurological examination was non-focal, after second dose of haloperidol, patient developed significant Parkinsonism. Haloperidol was discontinued and the delirium and Parkinsonism resolved over 3 days. Again, typical sensitivity to neuroleptics. Typical neuroleptics. On referral, there was no Parkinsonism present, but blood pressure changed from 136/84 in sitting to 110/70. This is clear postural hypotension, which shows autonomic dysfunction in these patients. Some complaints of dizziness, lightheadedness. There might be episodes of syncope also coming in. Significant memory impairment without benefits from cueing. Mild deficits, in orientation to the date or day of the week. Impaired clock drawing. The family was interested in a potential treatment with monoclonal antibodies against A beta protein. So initially they were still thinking in lines of AD, but this one history where the patient, showed Parkinsonism with haloperidol is something which made them suspect on the other lines. The patient developed significant Parkinsonism. It was discontinued. The delirium resolved over 3 days, but it happened once haloperidol was given. So due to the recent turn of events that happened in this ICU for this woman following her UTI, that is suspicion of dementia with Lewy bodies rather than AD as a diagnosis. A skin biopsy was done, detected presence of alpha-synuclein, showed phosphorylated alpha-synuclein deposition in 2 of 3 sites. You can see this. These are all alpha-synuclein deposits in the skin biopsy. So the findings enabled the neurologist to have an informed discussion about the diagnosis and assisted. So this is a typical case where initially when the patient was thought to be having Alzheimer's, later we found due to this one symptom of sensitivity to neuroleptics made us think now in terms of DLB. So that is a typical example of how DLB is manifesting. And this is just another case. It's just the same thing all over. That leads me to my second thing on dementia with Lewy bodies. I would want to know if there's any doubt which comes from your end before I move in to the last segment, which is frontotemporal dementia and vascular dementia, which will ultimately end my presentation. So I would want you all to reach out first and let me know whether dementia with Lewy bodies and Parkinson's disease dementia, which are both a feature of Lewy body dementia, is clear to you all. And if there's any question that you want to share, I'd be more than glad to receive it.
Yes.
I'll be opening this chat window for around a minute. If there's
Yeah.
any question that I want that you want me to answer, I'd be glad enough to reach out to you.
Alcohol-induced neurocognitive disorder. I
I'm
think
not
that's
I'm not
already.
able to hear you, Kavina.
Am I
Can you
audible
just
now?
repeat? Yes, you're audible, Kavina. Can you please
I
repeat it
think
one
this
more time?
question is already answered. Alcohol-induced neurocognitive disorder.
Yes. I think I've already answered that question. We have
Now,
already taken that slide up.
okay, if we are done with the webinar, can I just put the certificate link?
No, I'm just left with one more section of my slide which I would want to show, and then that would be concluding, which will just take me maybe around another 10 or 15 more minutes. That'll be it, because we started a little late. So I would just want to end that with frontotemporal dementia. After that, you can post the link for the certificates,
Sure,
Kavina.
sure, sure.
Yeah.
So, yeah, there is no questions for now.
Okay. So I'll move on to the last segment, and I'll be sharing my screen again.
Sure, sure. Thank you.
So my last segment involves two major dementias. One is frontotemporal dementia and a vascular dementia. When I talk of frontotemporal dementia, I'll predominantly talk of this one variant, which is called the behavioral variant of frontotemporal dementia, wherein again the real deal is all about this structure, which is called the PFC. It's called the prefrontal cortex. And when I talk of prefrontal cortex, I told you I cannot emphasize how many number of times how important that prefrontal cortex is, because uh, initially I always used to wonder why this disease is called frontotemporal dementia, because there's not much of temporal involvement that at all you find in this dementia. It's more of the prefrontal cortex which is involved, but then probably it's just remained a misnomer. So when I talk of prefrontal cortex, there are prefrontal cortex has a huge role in executive functions. It has a huge role in motivation. It has a huge role in behavioral patterns of a patient, and as I said, it's the gateway of it's the gateway of the mind. Basically, it tells us how to be, what it is to have a conscience. It will All of these things are going to get involved in these patients with the frontotemporal dementia. Mainly comes with the behavioral variant, as I said. Early behavioral disinhibition. You'll have socially inappropriate behavior. You have loss of manners, decorum, impulsive, rash, or careless actions. You have early apathia. There'll be, the patient will be absolutely mum to anything that is happening. Maybe there's someone dying around, and the patient will absolutely have, lose, interest in all forms of activities around. The patient will not want to do the things which he or she used to earlier do. And early loss of sympathy or empathy, as I said, the patient will keep on making hurtful to the family members without understanding that, okay, it's hurting someone. Usually when we make a comment, we usually realize, right, it's hurting someone else. This diminished social interest in activities that the patient wanted to do. They'll stop going to gatherings. They'll stop enjoying things which they earlier wanted to do. And simple movements will happen. Complex compulsive ritualistic behaviors, as you see, all of these things, they're all things associated with the prefrontal cortex, which is why I said I don't know why, we still don't know why, in fact, in spite of having such a minimal temporal lobe involvement, we keep on calling this as a frontotemporal dementia. Predominantly the behavioral variant, I'll say it's predominantly the prefrontal cortex. There's nothing more than that. And as I said, there'll be hyperorality. This hyperorality, in fact, is the only thing which is a temporal lobe change. Hyperorality means the patient will want to eat the same thing every single day. If you give them kacha carrots, they'll be like, no, I want to eat this. I want to eat this only. The only thing. The patient will have you know inedible objects. The patient will want to eat. Like the patient will probably take those the chocolate wrappers and put them in his mouth, and just say that no, it's very tasty, although there's nothing, it's just a wrapper. So all references, binge eating, excessive consumption of alcohol, cigarettes. Why am I telling you all of this? It's because when you even for the most common cause of dementia in India, which is Alzheimer's, even for an Alzheimer's patient, it's very important that you take these histories. These negative histories have to be taken first, so that you rule the other causes out. It's very important that you rule the other causes out before you diagnose someone as any form of neurocognitive disorders, to be honest. And relative sparing of episodic memory. Why? Because the hippocampus is not involved. The episodic memory is hippocampus is intact, episodic memory is intact. Relative sparing of visual spatial skills. Why? Because the association areas are intact. So total problem with prefrontal cortex. loss of apathy, loss of emotions, loss of good behavior, loss of conscience, doesn't know what he or she is doing, hyperorality, which is the only temporal lobe feature, to be honest. And along with that, you're having imaging, which is showing you frontal and anterior temporal atrophy and hypoperfusion and metabolism on PET and SPECT. So let me show you this. As I tell you again, this is all the features of behavioral variant of frontotemporal dementia. You can see this very clearly. The behavioral variant. Just a minute. And all of this is accumulated in these patients. Anytime I'm having a case of FTD, it's all accumulation of these things of TDP43, which is also called the PIX disease. So frontotemporal dementia for a lot of years has been given that one particular name as PIX disease. There's another variant also to frontotemporal dementia, which is not something which you usually encounter, but then it is all the non-fluent or the agrammatic pattern where predominantly it's speech disturbances. You have agrammatism. They'll say she go mad or she go mal. She go market. They'll not use verbs. They'll not use adjectives. They'll not use nouns properly. There'll be a full speech with inconsistent speech. There'll be a lot of distortions. You cannot repeat the words which have a difficult pronunciation, like say catastrophe. They cannot repeat that word catastrophe. I've seen patients who will not be able to spell the word psychiatric. So mainly associated with speech when we talk of the non-fluent variety of the primary progressive aphasia. And spared object knowledge. There'll be a spared single word comprehension, which means if you show these patients a pen, they'll be able to, they'll be able to identify that yes, it's a pen. So that is all about the speech part of frontotemporal dementia. But as I said, when I talk of frontotemporal dementia, it's predominantly the behavioral variant, which will always most likely come to you with, the disinhibition, socially inappropriate behaviors, loss of conscience and everything on those lines. Okay. Coming to the last one, as I said, it's vascular dementia. Vascular dementia is something which is a major contributor to age-associated cognitive decline. If there's anyone who's having a cardiovascular risk factor, like a previous history of TIA, stroke, MI, atrial fibrillation, all of this, hyperlipidemia, hypercholesterolemia, all of this are going to contribute to an increased predisposition to vascular dementia. There are four types. One is the post-stroke dementia, which occurs within 6 months of a CVA, predominantly a hemorrhagic CVA. And the MRI is showing evidence of chronic vessel disease. What do you mean by MRI showing evidence of chronic vessel disease? Either there's a subcortical lacunar infarct, or there's microhemorrhage, microinfarct, or white matter hyperintensities, which are there, which can be either signs of demyelination, it can be signs of axonal loss, inflammation, or even in early Alzheimer's disease, you can find white matter hyperintensities, which can be found. These are the typical features or MRI evidence of small vessel ischemic disease, where you find these areas which I want to show you. These are predominantly periventricular areas, and they are having a higher flare sequence that you get in figure B. You can look at these segments where you find subcortical lacunar infarcts being present. I'll zoom it out for you. These are the lacunar infarcts that you get, predominantly involving the putamen and the caudate nucleus. And you can also get cases where you will have cases of siderosis. Even hemosiderosis is something that you'll get. You can even get cases where you're having basal ganglia, microbleeds which are found. These are areas of basal ganglia where you are finding microbleeds, little bleeds. If you can see this, these are basal ganglia microbleeds, which again point out towards vascular dementia. And these these cerebral microinfarcts, they are what basically leads to the major pathogenesis of vascular dementia. Neuronal loss, there's gliosis that you find. All of these are hyperreactive changes due to the surrounding neuronal injury or the cellular injury that is happening. And as I said, most patients with Alzheimer's, because as I said, age is an independent risk factor for Alzheimer's. The older the patient, more is the risk. In these patients, you have a higher predisposition of hypertriglyceridemia, diabetes, MI, atrial fibrillation, stroke. So it may exist independent of concurrent AD, and it can add up to the cognitive burden in older individuals. So often a patient with Alzheimer's disease, you have to rule out through MRI whether there is any structural brain damage. That is why MR plays such an important role in the diagnosis of any neurocognitive disorders, because you then understand that, okay, whether this is just a structural brain damage, whether there's a lacunar infarct, whether there's an infarct which is present, or whether it is something which is just a typical hypoperfusion or a hypometabolism which is occurring. That leads me to my final slide, which is just a sum up of whatever we have learned today. Whenever I'm evaluating a case of a neurocognitive disorder, I have to, of course, rule out the reversible causes. That's the first thing that I have to do. And I have to first see whether memory loss is the earliest thing which is coming. If yes, I should think in terms of Alzheimer's, but I should also find out the other domains. As I said, also find out the other domains. If memory loss is not there, if memory is normal, I should look at language. If language is a problem, then it's frontotemporal dementia. As I said, it's the aphasic variant of frontotemporal dementia. If if language is normal, then we look at attention or executive function. If that is involved, is the behavior involved? If the behavior is involved, again, it can lead me to a diagnosis of frontotemporal dementia, which is the most common variant. That is the behavioral variant of FTD. If attention or executive function is involved, is it a case of behavior? No, it's not a case of behavior. Are there extrapyramidal symptoms present? Okay, then is it a case of Parkinsonism? If Parkinsonism, is it also associated with visual hallucinations? If yes, it's dementia with Lewy bodies. I have to also see the timeline when it started to originate. If not, I'll have to think in majorly in terms of Parkinson disease or Parkinson plus syndrome. If none of the above features are there, this patient is an old age patient, or is a patient who has already had many cardiovascular risk factors like hypertriglyceridemia, hypercholesterolemia, previous MIs, or a history of stroke, early TIA or stroke in the family, early cardiovascular death in the family. All of these risk factors are present. I should always rule out a structural brain damage, finding of microhemorrhages, microbleeds in MRI to rule out vascular dementia. Another thing, again, it's very theoretical, but for students who are in their MBBS days, if there's one line which you come across that's a stepwise progression of a dementia, it is always vascular dementia, unless proved otherwise. As I said, there'll be no strokes. And there's one more entity which is called CADASIL, where again, this patient will not have cardiovascular risk factors, but CADASIL is like cerebral autosomal dominant subcortical infarcts with leukoencephalopathy. Basically, what happens is these patients have a typical presentation, very positive family history. In the 20s, these patients will come with migraine. Main gene mutated is usually NOTCH3, and by the time they go to their 30s and 40s, they will start having recurrent strokes. So migraine in 20s followed by strokes recurrently happening in the 30s to 40s is something that should make you think about CADASIL. By the time they are in their 50s, you will have changes of subcortical infarcts, which points out towards vascular dementia. Another thing, which is if none of these are positive, if CADASIL is also not positive, we come across this called normal pressure hydrocephalus, where you have this typical triad where I talked of, where it's also called the Adams or Hakim's triad, where you have subcortical dementia, you have urinary incontinence, which is a very late sign and usually indicates a poor prognosis, and there's a gait apraxia. There's a typical magnetic gait. I want you to go to Google once and type this Hakim's triad so that you can find how this patient walks. It's a typical magnetic gait, and the first sign. And because of this, there's recurrent falls that happens in this patient, which leads to fractures in the elderly. This one slide is something which has been made like with a lot of effort, and I would want you to once always go through this slide, because this is actually the total summary of what we have discussed, about how to go through the different cognitive domains and find out what and where is the underlying problem. But as I always say, never be very biased on what I told you today, because every symptom can coexist. There are many symptoms which can come with one another, so it's always important to follow these patients up. Following up a patient of neurocognitive disorder has often resulted where one diagnosis has actually changed to being something else, because these patients were followed up over a long period of time. So following up repeated clinical evaluations, radiological evaluations repeatedly are not usually recommended, but repeated clinical evaluations is something which will always open up the door for diagnosing a multiple variety of neurocognitive disorders that we usually encounter in these patients. So that's all from my end. I hope I could do justice to this topic, because it's a huge topic. To be honest, it's one thing where a neurologist, a proper person neurologist, is going to teach you this topic for days. Trust me. To sum it up in 2 hours is very difficult. But then I tried to give a deeper insight to the major neurocognitive disorders that you have, mainly in the form of Alzheimer's and Lewy body and frontotemporal dementia, as much as I could. I hope you enjoyed the session, and I hope that you can get some benefits out of it and read over it. So that's something which I'll always say. It's not what you get from here. Please read over and above what I am telling you, because it's I am not the I am not the holy Bible or the authority of everything. I can only give you a stepping stone. It's for you to build upon that, for you to read upon that, and the more you see patients, if you have this interest in this field of neurocognitive psychiatry, it's where you go to these patients, where you take detailed histories. Do not be biased. Be polite. Be as caring and compassionate that you can, and take a detailed history and grow up from what you've learned in this webinar today. That is something which I'll request all of you, because it's a learning process for me as well. Grow up from, build up. If there's any way that you can connect to me in the next webinars, write to me what else you have learned, what else you have known, and that is how we all grow together in this profession. That is something which I believe in. So lots of love to all of you for being there. Kagana, you can address them right now. I think there are no more questions, but you can always like talk on it.
Yeah, I think so. There's no questions
Yeah.
because as we have started in the morning, like started, and in between we have actually put some questions. So
Yes,
there's no
yes.
questions.
I think there's someone who's wrote, it kept me hooked with your easily comprehensible. Yeah, I know it was a long session. Again, as I said, there are things which cannot be done in 1 hour. I always say this, that in life you can't get everything short. Maggie is a 2-minute noodle, but it's not ultimately good for your health. So that is something which I always believe in. So the topic is such, if I have to take you through neurocognitive disorders, as I said, a proper neurologist is going to take days. In 2 hours it's very difficult, but then I can only give you insights. My work is not to follow, like, okay, I start at a time and I finish at a time. I can easily do it, trust me. I can give the same content in half an hour, but I would not be benefiting you. I'd be cheating my own work, and that is not something which I believe in. As medicos, as you all are medicos, I believe you're here to build up from what I give you. That is what I'm trying to encourage you, to give you information which somehow sparks the gray matters in your brain, because you are all junior to me mostly, and you are all supremely talented people, I believe. So my big heart and love to all of you for being that.
Sure. Thank you, doctor. I think there are no questions, so with that we can
Thank
wind
you.
up.
Yes, absolutely.
Thank
Thank you to all the
you.
ones who have joined. Not able to name each one of you individually, of course, but I'm really grateful to all the ones who have joined, who have posted your questions, and I'll be really glad if you post in suggestions by which we can make these seminars better. So lots of love to all of you. Good night, and I wish you all a very, very, very happy New Year, very prosperous New Year. I hope this gives you a good time with your family, and everyone in your families and loved ones stay well. So spend in love, spend in harmony, and just keep studying. That's the maximum that we can do, I believe.
Yeah, sure. Thank you so much, Doctor.
Thank
Thank
you.
you all
Thank you
for
so much.
joining us today. We hope you found this webinar informative and valuable. I have already dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. If you have any further questions or would like more information, please feel free to reach out to us. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening. Thank you all.